Dear participants of the conference, we are going to start in 1 minute.
Assalamu alaikum.
Dear participants, we are ready to welcome you to the second day of Scientific and Practical Conference New Horizons in the diagnosis of oncological and oncohematological diseases in children. We also have today very brilliant speakers who will be here face to face, and they will be also online here, and we are going to have different topics and it will be very interesting thing. Today is our second day of our conference, and we are still discussing the oncological and oncohematological diseases in children. And of course, there are a lot of materials which will cover this topic, and we have experts and we have specialists in this topic, and we are going to really handle this topic from the different aspects. And of course, today we will have different topics, diverse topics, and we hope it will be very useful for you. And our scientific and practical conference on the topic of new horizons in the diagnosis of oncological and hematological disease in children. We are going to start. Everything is ready. Moderators are ready. Let me first introduce our moderators. Eldor Jasurovich Ishakov, the doctor and of the hematologist, and he is the head of the cathedral in the Institute of Perfection of Doctors. Good morning, doctor, professor. And also, please greet Amanov Ardak Hamitovich. Welcome. He is specialist. He came here especially for participate in this conference from Kazakhstan. Welcome. And also, please greet our guests if it's possible. So we should start, right? Dear friends, frankly speaking, the hematology and oncohematological, oncological, it is really developing very fast, and we sometimes not very actually are on the track with the news because it's developing very fast. So our task is to be aware of everything is going in this sphere, and I think if we will be going with the time with our colleagues from abroad, and then we already have the support from our government, from the Ministry of Health. I think within like very short time we will be there also, and we will be equally aware with our European colleagues, with our other colleagues from abroad. And I want to say that recently in our country we have revolutionary things, and I think that it is because of our doctors, excellent specialists who are working day and night 24/7. Like they are constantly working, and they are applying their knowledge, experience and strength to help our patients, everyone, at the place. It can be nurse, it can be doctor, it can be the head, it can be the director. Everyone is doing the same thing, saving lives of the children, saving lives of the patient. Today we have the second day of the conference, and yesterday we had brilliant reports, presentations, and I would like to give floor to our colleague from Kazakhstan. He is my dear friend and colleague, Arda Hamidovich, please. Just a few words of greetings. Good afternoon, dear colleagues. As my moderator and friend said, we know each other since 2012. It was sub-regional seminar organized by Russian Bureau of Health. It was in the city of Bishkek, and from time to time we see each other in the conferences like that. I'm a doctor, and I am actually in oncological since 2013. I also was a part of bone marrow transplantation for adults, and we have in Kazakhstan also an issue that we should meeting all requirements and standards, because the transplantation of bone marrow, and that's why we have like oncohematologists, rheumatologists, and transfusiologists, and we have a challenge according to these requirements to go through this difficult pathway to start it, to really make it, because it's also in the cells and organical. And I'm the first time in Tashkent. I'm very glad to be here in this conference. Thank you very much for honor to be a moderator, and the purpose of my visit to help my colleagues at this stage, and I hope it's not my last visit. And I am really waiting for you in Astana, and transfusiology is a very wide topic, and we are ready to share regarding it a lot. Thank you very much. And also I would like to remind about the deadline. Every speaker has 15 minutes, and now today we are going to talk about innovative methods of diagnostics and treatment of hematological diseases in children. And we are going to give floor Davlatova Gulchehran Najmedinova, PhD. Please, the floor is yours. Good morning, dear guests of our conference. Good morning, dear colleagues. I am really grateful to all guests who are now with us with this conference, and of course for opportunity to giving report with you. And my topic is modern aspects of etiopathogenesis, diagnostics, treatment of patients with B thalassemia. I need help to understand how to click it. So, hemoglobinopathies are among the most serious and widespread monogenic hereditary diseases, according to which, or about 5% of the world population are currently carriers of potentially pathological hemoglobin gene. B thalassemia is a severe autosomal recessive hereditary disease that develops as a result of mutations in the B globin gene. Thalassemia is a heterogeneous group of genetic diseases in which normal hemoglobin production is partially or completely disrupted due to a defect in the synthesis of one or more globin chains, and severe anemia develops. alpha, beta, gamma, delta types of thalassemia as well as their combinations. According to the literature, the most common monogenetic diseases worldwide are alpha and beta thalassemia. The thalassemia was first described by Cooley and Lee in 1925 when they observed 5 children from Italian families. All children in the family had hypochromic hemolytic anemia with a significant enlargement of the spleen and liver and changes in the bones of the skeleton. The disease was called Cooley's disease. Later, milder forms were described, and in 1936, the disease was named thalassemia. And according to the different statistics, we can say that the number of carriers of B thalassemia in the world is 5 to 7%, and of clinically manifested signs of thalassemia are 1 to 5% of the world's population, and more than 2.5 are accounted for by annual births. In total, there are about 270 million carriers of genetic variants associated with the formation of abnormal hemoglobin and thalassemia in the world, of which 80 million are carriers of beta thalassemia mutations. Recent studies indicate that between 300,000 and 400,000 children are born each year with severe hemoglobin abnormalities, and that up to 90% of these births occur in low and middle income countries. In connection with the above, this hemoglobinopathy is considered a huge socioeconomic burden of health, especially in regions with a high prevalence. And thalassemia have a high prevalence over a wide area extending from the Mediterranean basin and parts of Africa throughout the Middle East and an Indian subcontinent, Southeast Asia. Beta thalassemia is most common in the Mediterranean and the countries of South and Southeast Asia. There are especially many carriers in Italy, Greece, India, in different subpopulations, Nepal, Thailand, Indonesia. Among the countries of the former Soviet Union, the disease is a serious problem in Azerbaijan, Armenia, Georgia, and Moldova, and the republics of Central Asia. In Russia, as in many other countries of the world, USA, Canada, Latin American countries, the problem of the beta thalassemia is associated with immigration processes. Beta thalassemia, there are large shape, intermediate, and small form, and alpha thalassemia minimal and carrier hemoglobinopathy. The main hemoglobin adults is hemoglobin A, HbA, including A and 2 alpha and beta chains, and it makes up about 95 to 98% of the hemoglobin found in adults, and hemoglobin A alpha makes up about 1.5 till 3.5% of the hemoglobin found in adults. And about hemoglobin B, you can also see on the slide. And the diagnostic criteria, we really need to pay attention. We need to really have good anamnesis. Attention should be paid to the presence of relatives with the diagnosis of thalassemia, family history, and the presence of family relationship between parents and grandparents, and of course complaints of patients. About the diagnostic criteria. The main diagnostic criteria for making diagnosis are blood analysis shows anemia of varying degrees, microcytosis of erythrocytes, hemoglobin of erythrocytes, presence of target erythrocytes, and normal blasts, presence of symptoms of hemolysis, and accelerated erythropoiesis, changes in hemoglobin fractions according to hemoglobin electrophoresis, data table, somatic disorders, and you need to make a basic studies and to establish clinical laboratory diagnosis diseases. It's needed to make a general blood test, in which is necessary to pay attention not only to the concentration of hemoglobin but also the number of red blood cells and etc. A biochemical blood test, which focuses on the concentration of total bilirubin and its fractions, the study of hemoglobin fractions by capillary electrophoresis or high-performance liquid homography, DNA testing of also globin globin genes allows to identify both point mutations and deletions, loss of gene fragments of varying lengths. And we have treatment, and we also do the main goal of thalassemia is to prevent hemolytic crisis, and the goal of treatment is to eliminate the manifestations and complications of thalassemia associated mainly with hemosiderosis of organs, to stop the developed hemolytic crisis, reduce and prevent progression of hepatomegaly and splenomegaly, improve quality of life, conducting chelation therapy, which allows you to remove excess iron from the body. Continuous chelation therapy at the initial stage of thalassemia diagnosis allows maintaining iron levels in the body at a safe level. And today there are different treatment and medicines we have. It's like different injections, eteroxim, and others. Let us talk a little about hemotransfusion therapy. And the treatment of thalassemia major involves regular blood transfusions throughout life, usually every 2 to 5 weeks, to maintain the pre-transfusion levels. And regular blood transfusions can cause damage to the liver, heart, as well as the lungs, endocrine glands, and the other organs. And that's why certainly worsen the patient's condition, and is left untreated can even lead to death within a few years. Prevention and treatment of iron overload are carried out, but even they can't always help person. Therefore, other methods of treating thalassemia are being developed. In particular, in 2020, a study of the drug luspatercept was developed and conducted, which in theory should reduce the number of transfusions in patients with thalassemia, and therefore reduce the frequency and severity of complications. And according to the results of this, based on the 12-week interval studies in the study, the percentage of patients who had a decrease in blood transfusion burden was greater than 33%. And also, we see that after this treatment and after the hemolytic stem transplantation, it show very great results. Around 90% of patients, they really are being treated. And of course, the general medical care and lifestyle for thalassemia is very important. If the disease is fully compensated with the best treatment regime, the patient's thalassemia major can lead a life similar to a normal peer and go through all stages of physical and emotional development from childhood to adulthood, including the experience of having children. Regarding the nutrition, patients with thalassemia do not adhere to specific dietary requirements unless there is special indication or concomitant diseases. Based on the decree of the President of the Republic of Uzbekistan, PP 4440, on measures to further improve medical and social care for children with rare, orphan, and other hereditary genetic diseases dated September 7, 2019, chelation therapy is carried out in the Republic of Uzbekistan using drugs from the state budget free of charge. It is deferoxerox. The drugs are distributed to all regions by the Ministry of Health of the Republic. The introduction of the chelation therapy allows to increase the life expectancy of patients, reduce mortality, and improve the quality of life of the patient. In 2021, the patients with thalassemia, specialists of the Anemia Center, the Republic Scientific and Practical Medical Center of the Republic of Uzbekistan, created a thalassemia charitable public fund. This allows a group of parents of patients to exchange information and experience on a daily basis. In 2024, the Ministry of Health of the Republic of Uzbekistan approved national protocols for the diagnosis and treatment of patients with the beta thalassemia, and we are doing research according to this. So currently, studies of molecular genetic analysis of beta thalassemia are being conducted in Uzbekistan. To conduct a clinical study, a selection of patients with hemolytic anemia who apply to the polyclinic of the Republican Specialist Scientific and Practical Medical Center of Hematology of the Ministry of Health in the Republic of Uzbekistan in the period from 2019 to 2024 was carried out using the method of continuous and selective analysis. The study material included 213 patients undergoing treatment at the Republican Scientific and Practical Medical Center of Hematology. A research method, the study used general clinical molecular genetic studies, PCR studies, and standard sequencing, clinical and genealogical analysis. And we can see what was in 300 We can see that among patients, based on the results of visits to the clinic, the following was revealed. The largest number of patients were noted from the Surkhandarya region. It was 15%, Tashkent city 13%, Tashkent region 11%, and Kashkadarya region 10%. This in turn confirms the importance of the causes leading to the emergence of the disease, that the problem of beta thalassemia is also associated with immigration processes. The highest risk of having children with thalassemia is in the regions that are part of thalassemia belt, and in those where there is high incidence of consanguineous marriages. Such regions include Surkhandarya, Kashkadarya, Samarkand, and Bukhara region. In the city of Tashkent, where many families from these regions live. The research of the prevalence of consanguineous marriages showed that consanguineous marriages among patients were observed in 43% of patients, and unconsanguineous marriages in 56% in the breakdown by regions. The following were revealed. Surkhandarya region. That's why we can make a conclusion that it can be concluded that both consanguineous marriages and unconsanguineous marriages in families of patients can lead to the development of the disease. The age of patients varied from 1 to 51 years, and median was 4 to 8. Of these, 196 patients were children under 18 years of age, and 17 or 7% were adults. This can be attributed to the fact that children, namely at an early age, begin to show clinical symptoms of thalassemia, who are diagnosed with thalassemia after visiting a hematologist. And among the among the 213 patients with thalassemia, the following was revealed by gender: 62% boys and 37% girls. There are 2 times more boys. Those boys get sick more often than girls. Our data inconsistent with the literature data. Out of all patients, examined patients, 36% were found to be homozygous and 63 heterozygous. The hemoglobin structure in the chromosome form of MGB thalassemia 6%, analyzing hemoglobin NBase is absent, and HbF is 92 to 95 the total hemoglobin, and heterozygous with beta thalassemia on average it was characterized by NB 92 to 95 with HbA 3.8 and a different amount of fetal hemoglobin up to 4%. Those are results of the conducted studies of the modified biochemical method based on beta-globin immunofluorescence for the basic diagnosis of thalassemia are associated with a high-tech molecular genetic method. Among the examined patients with thalassemia, the 1 patient was found to be homozygous carrier of the beta thalassemia mutation, which was found not in the HBB database. It was 3 polymorphisms in homozygosity and 2 polymorphisms in heterozygous condition. So we also see that there were mutation. So today, this research continues to identify heterozygous carriers of beta thalassemia in the Republic of Uzbekistan. It is necessary to create a new diagnostic screening panel designed to identify beta thalassemia carriers for our region. With its help, patients will undergo screening diagnostic methods. Identification of heterozygous carriers will allow prenatal DNA diagnostics in early pregnancy and post-implantation diagnostics to reduce B thalassemia. It is planned to develop a database of mutational spectra of the B globin gene in Uzbekistan, which will serve as the basis for the creation and implementation of special state programs aimed at reducing beta thalassemia in Uzbekistan. Thank you very much for your attention. Thank you very much. And I think if you have any questions to speakers, please you can ask them right now, or you can also maybe moderators they have questions. First of all, thank you very much for your report. I think thalassemia is an orphan disease, but still we have these patients and we need to help them. My question is, I'm not sure on the legislative framework. Do we have any recommendations about these marriages. For example, if there is a suspicion on thalassemia, so before the marriage, do we have like some research, like in Azerbaijan? Thank you very much, Eldar Jasurovich, for your question. On the example of Azerbaijan and other countries' practices, we see that it is necessary. We need to have before the wedding. We need to, like, we have the research, right? We need to research on the blood analysis because it is very good if we can do it. And now, actually, right now, we are working on this, and so it's in the process, right? Yes, it's in the process. Okay, question, please. I think that the prenatal screening is already there, but about regions, do we have these problems of access to this screening? Because in Tashkent, of course, it is like one screening, and what about regions? Look, in our institute, we have molecular genetic laboratory, and it is going through the first, like actually went through the first stage, which to be like recognized in the world, this research, and this research we would like to integrate to the regions, but currently it is only in our center, like in private clinics also, but if we talk about state government medical entities, no, not really. And what about like how many researches you can do on prenatal screening? Like how many? Actually, today in Republic of Uzbekistan, the patients with thalassemia is 367 in children, and not a lot of adults with thalassemia. So in the period of our research, we want to really learn the spectrum of mutations, the heterozygote carriers, and it can be like many, and we're still working on this, really. Thank you very much.
We want to thank you as well. It was very insightful information, if we allow. And we will continue. And now the floor is given to the next speaker, Kaliva Aygul Janibekovna, pediatric oncologist, hematologist. The topic, the modern approaches to rehabilitate children with oncological diseases in Kazakhstan, problems, perspectives, as well as the ways, paths to develop. Good morning, colleagues. First of all, I want to thank for the warm invitation, for the hospitality, for the organization of this valuable conference for the pediatric oncologist, and for providing me possibility to have a floor. My topic is modern approaches to rehabilitation of children with oncological disease in Kazakhstan, problems, perspectives, and the ways of, to move forward. In May 2024, the WHO, first time in 75 years, they approved the resolution to strengthen the rehabilitation in the sphere of healthcare. This is the first document which defined the importance of rehabilitation in every sphere of the healthcare. And now, due to the fact that the last 10 years we can see that the disease is moving towards from concomitant diseases to non-concomitant diseases, and rehabilitation is considered to be an important part of the treatment. And this document became a revolution in the rehabilitation sphere, and it shows that rehabilitation is important in every sphere. And of course, for the pediatric oncohematology, rehabilitation should have to be conducted not only within the first, second course when they are getting the treatment, but after the treatment as well. Because for the last 10 years, more than 1% of adult population, they will comprise of children who were treated from oncohematological disease. That's why this is an important topic. This is the drawing, just a recent drawing of my patient who is within the remission for about 2 years. She has a medulloblastoma. The first time within 4 years she started to draw, and it became possible by the help of the program of rehabilitation, because she got rehabilitation first time in her life. She could hold this pen and made this kind of a drawing. This is the Share picture. All of us, we are glad to see when the child starts walking, but when the child first time starts walking in 10 years, this is something very emotional, because the child after oncological disease who had certain complications, quite common, they start learning first time in the age of this age, and everything is conducted by the help of rehabilitation program. In Republic of Kazakhstan, every year we register 600 new cases. The disease level is 1,400 per 100,000 people. Today we can say that clinical remission is seen in 80% of the patients, and more than 60% of patients, they have 6 years of remission. It is considered, if there is a clinical and histological remission, then we can consider it to be recovered. And in Kazakhstan, we have a big amount of children with different disease. Children who underwent oncological disease, usually they have a bad physical health, fatigue, depression, reduction of the cognitive potential, have difficulty in studying, bad feeling in comparison to the healthy peers. And even though there is a remission period, the recovering might take few years. The basis of the medical rehabilitation, it comprises of the certain complex of measures in order to prevent, diagnose, as well as the full or partial recovery of certain parts of the body which are violated. And those are the measures in order to improve the quality of life, decreasing the disability level, as well as the social integration of this child. There are a lot of children who were recovered from oncological and hematological diseases, in the whole spectrum of the disruptions within their body. Why? Because child, he is having a developing of every system, and when we provide them chemotherapy or radiotherapy, this homeostasis is binding towards the disruptional points, and that's why they have certain problems after they get the treatment. Rehabilitation of children after oncological disease, it includes certain key directions, such as medical rehabilitation, which comprises physiotherapy, neurorehabilitation, endocrine correction, cognitive and psychological rehabilitation, which includes psychological support, cognitive training, social adaptation, such as inclusive education, as well as psychosocial support. Lately in Kazakhstan, we implement inclusive education. All the children who had certain diagnoses, they can study, not in the specialized schools, but nowadays in the general schools. Physical rehabilitation, such as different physical activity, adaptive sports, online consultations, and etc. One of the problems which is not solved, based on the reports of the Minister of Health of Kazakhstan from 15th of February 2022, is considered to be the rehabilitation of children with oncohematological disease. That's why the aim of my research were to really reveal the problems in this direction, to develop clinical recommendations and organize targeted educational measures, activities in order to improve the quality of life of patients after finalizing the specialized therapy. We know that rehabilitation is important for the oncohematological patients, but in order to prove the relevance of this problem for our government, we had to provide this kind of research. It is not published yet, the results. That's why I'm not showing all the results here. And within this research, there were 300 children and teenagers who had the tumors of the CNS, who finalized their treatment from the period of 2020 up to 2023. The minimal, the observation period was 1 year. The maximum was 3 years. So why this kind of contingent of children, because in every sphere they have certain problems. That's why we chose them, and the methods of observation, it was of standards. It included physical checks, laboratory checks, clinical, biochemistry, and the hormonal phone, the instrumental ultrasound investigation, the assessment, electromyography, and CT and etc., as well as the specialist examination was conducted based on the needs. And so basically these checks were conducted after the chemotherapy treatment. The general characteristic of the patient, the median of the age on the diagnosis time, it was 9-year-old. At this time, 150 children, they received specialized therapy in the age of less than 10-year-old, and boys were 170 and girls 130. The distribution of the patients based on the gender differences for the treatment moment was like this: before puberty, 183 children, and during the puberty 93 patients, as well as after puberty 24 children. The diagnosis was medulloblastoma 75, ependymoma 30, preventive neuroectodermal tumors 45, astrocytoma 60, glioblastoma 24, high-grade glioma 21, low-grade glioma 36, atypical thyroid tumor 40. And they are conducting this kind of standardized surveys in order to reveal the quality of life. Clinical skills are used in order to find the social integration, the contact with peers, as well as the relatives, and etc. And the question should have to be responded on the scale from 0 to 5 points, where 0 is considered to be bad and 5 is usually never happens. And those kind of questions were asked among the parents if the children are less than 5 years. If they are higher than 5 years, then the questions were asked from children straight. What did we do? We also considered the check of the anthropometric measures as well as psychomotor development. In addition to that, we conducted psychological support assessment of children, the general assessment of the children with CNS tumors who underwent the treatment. And out of this 289 patients who were within this investigation, and late complications were recorded in 283. 22 children were excluded from the study due to the relapses of the disease. Damage to at least one organ or system associated with the received chemoradiation therapy was registered in 214 patients. Most patients had combined late complications. For example, 94 cases of endocrine pathologies were identified, including reproductive dysfunction, the thyroid pathology, growth and physical development disorders, and metabolic disorders. Non-infectious lung lesions were detected in 9% of all patients. Cardiovascular pathology in 56 cases, and others were revealed. All of them, they have certain neurological function as well as physical disruptions. As a result of conducted investigation, it was found that 98% of all children, they had late complications such as neurological disorders, endocrine disorders, lung problems, and cardiovascular diseases. These complications can manifest themselves at an early and late stages after treatment and have a variety of physical, emotional, and social consequences. A significant number of children experience a decline in physical condition, emotional difficulties, and problems with social adaptation, which emphasize the need for a comprehensive approach to their rehabilitation. Shows that it is needed to have a complex approach for this rehabilitation of these children. And currently in Kazakhstan, there are next problems in the system of rehabilitation. Unfortunately, at the moment, we are lacking of clinical protocols for the rehabilitation of children with oncological diseases. Currently, we just have certain standards to provide the rehabilitation of every nosology forms of the diseases, but they are not providing information about the stages of the rehabilitation. A limited number of specialists. That means that there is a lack of pediatric oncology rehabilitation specialists, psychologists, psychotherapists, and other specialized specialists. Insufficient funding. Limited resources allocated to rehabilitation programs, which impacts the quality and accessibility of services. Unfortunately, today, rehabilitation is conducted by the sponsor support. Lack of specialized centers, lack of facilities equipped with modern equipment and providing a full range of rehabilitation services for children with oncohematological diseases, as well as lack of awareness, low level of awareness among patients and medical staff about the possibilities and importance of rehabilitation. Due to the fact that our country is quite big, children from the different regions they are here, from the children from rural areas, unfortunately, they will be left without any attention there. Perspectives and the ways to develop. And nowadays there is they created the work group, and I will be the member of this work group. And this working group is already approved, and we are already working on the developing the clinical recommendations, training of specialists, such as conducting trainings and educational programs for medical workers in order to prepare qualified rehabilitation specialists, psychotherapists, and trainers in therapeutic physical education. Establishment of specialized rehabilitation centers, open institutions offering rehabilitation centers for children who have survived cancer will help to solve the problem of lack of resources for assistance. Establishing monitoring evaluation standards. Whatever is implemented, it should be controlled. Unfortunately, without that, the work would not undergone properly. Active support from society and government, participation of NGOs and government organizations in the initiative to support the rehabilitation of sick children, including funding programs and dissemination of information about availability of services. Successful implementation of this recommendation can significantly improve the quality of life of children who have suffered from cancer and turn them into full-fledged members of society, which is the ultimate goal of the entire treatment rehabilitation program. And plus, this is economically also feasible. It is better to if this patient who is healthy and recovered, he will work for the government, right? That's why the rehabilitation of children who underwent the cancer is a critical task. Given the variety of late complications and their impact on overall health, timely detection and intervention can minimize long-term consequences of treatment, improve quality of life, and ensure successful social integration. I want to show you the video, if it's possible. Those are all children who are under the remission stage. We have such a tradition every year. We organize the games of the champions. All the children who are under remission, they come to Astana, and we conduct this kind of sport activities. This tradition were copied from Russian Federation. The fund of the rehabilitation fund that they are conducting, they helped us to conduct the first champion game, and once a year we are meeting with our champions. Thank you so much for your attention. Gurjani Bekovna, thank you so much. Olga Alexandra, how do you think? Did they do this right? Of course. But I have certain questions left to clarify. Can you please tell me, when you talk about that there is no rehabilitation centers existing at the base of which facility and department you conducted the investigations of these 300 patients on the base of private rehabilitation centers? So private, they exist, yes, they do exist. Only by the agreement we could bring those children and allow them to receive rehabilitation. Okay, another question. Russian Federation. In Russian Federation, one of the new specialty is rehabilitologist. Yes, we do have rehabilitation doctors. Unfortunately, they are not conducting the rehabilitation of children with oncological disease due to the lacking of knowledge, probably. We have certain specialized rehabilitation center for the children to work with children with cerebral palsy, with different other disease, and they're afraid to work with our children because they do not know the volume of rehabilitation that is needed for the children. The last question, how do you think? Do you need to separately highlight the oncorehabilitologist so your patients should be then we need to raise the awareness. I think it is faster to teach those specialists, and within the process of rehabilitation, there should be the multidisciplinary groups such as oncologists, psychologists, and etc., etc. And we need to create the program rehabilitation together. Thank you so much. We want to thank you for your presentation, and now we have the next presenter, and it will be in a live format. And I will tell the name of the specialist, Aliva Nargis from the Thalassemia Center. She is the head of the Department of Transplantation of Bone Marrow Transplantation. The topic, transplantation of hematopoietic stem cells in patients with beta thalassemia in Azerbaijan. Are you here with us, connected? You can start.
Good morning. Greetings to everyone, to colleagues, to moderators. Today I would like to share about transplantation of bone marrow for patients with thalassemia. We started this treatment 10 years ago. I would like to show you our center, to introduce our center. Can you see? Can you see our presentation? No, we don't see your presentation, Ms. Nargis.
Нет.
No, unfortunately, we cannot see your presentation still.
Ребята с технической службы, подскажите, что нужно сделать.
Сейчас?
Unfortunately, okay, now we can see the presentation. We started transplantation of bone marrow in Azerbaijan in 2014, so it's 10 years we are working in this direction. As you know, the beta thalassemia is mostly common in Mediterranean poor. So let us start with what is thalassemia is. Thalassemias include groups of inherited disorders that result in the formation of chains of defective hemoglobin. The two main types of alpha and beta thalassemia are caused by an imbalance in the amounts of alpha and beta globin chains. The big beta thalassemia, the most common genetic disease in the Mediterranean countries, 200,000 patients. According to WHO, there are more than 180 million carriers. Today, 2,595 patients with thalassemia are registered in thalassemia center in Azerbaijan. Of these, 924 are on blood transfusion. If you look at the clinical classification of thalassemia, we can see the homozygous defect, significant imbalance of globin AB chains, severe anemia manifested early in life. Throughout life, they need blood transfusion. If left untreated, it usually results in death. Several genetic interaction. It's intermediate. Globin chain production is impaired moderately. Thalassemia, anemia occurring late in life, and blood transfusion may be needed. And we have thalassemia minor. It's heterozygous form, asymptomatic, and genetic counseling may be required. About the difficulties you can see on this slide, you can see it is the problem with endocrine system. This is the highest, and also we can see here the cirrhosis, so the problems with liver, and also the problems with heart, and it's also due to the big amount of iron in the organism of a person. About the transfusion, the main method of correcting anemia in thalassemia is red blood cell transfusion. In thalassemia major, to live, maintain, and improve the quality of life, all patients need regular blood transfusions from an early age. In thalassemia intermediate, transfusion may be required, and thalassemia minor, no transfusion required. Iron overload in thalassemia is inevitable when large amounts of blood are transfused and is potentially life-threatening. Each unit of blood contains 200 to 250 mg of iron. Iron accumulates in the body and cannot be removed. Iron overload can occur after 10 to 20 transfusions. Also, if we look at this slide, we can see the age distribution of patients with thalassemia. So it's mostly young people, children and young people. And if we see the consequence of excess iron accumulation, we can say that it leads to circulating plasma transferring not bound to iron, and then it leads to heart failure, cirrhosis, fibrosis, liver cancer, diabetes, infertility, and growth disorder. The sensitive organs to iron overload, clinical losses overload, it's pituitary, it's heart, liver, pancreas, and gonads. When we make assessment of iron in the body, it's a measurement of serum ferritin levels, assessment of iron concentration in the liver, and cardiac iron assessment. And as we already do T2, can you see MRI? It's a new standard for measuring heart iron. So what is chelatotherapy? And chelat itself is toxic and plus metal. It's a metal chelator and ejection. We use in our treatment desferoxamine and also deferral, which is bound 93 gram of iron. It's starting after 10 to 20 blood transfusion. We also give ferritin from the beginning, and we prescribe 5 days a week, 8 to 12 hours injections slowly, and also dosage 25 to 50 microgram. Regarding the complications of desferal treatment, it can be local reaction, itching, redness, ocular toxicity, hearing loss, slowing growth rate, changes in skeletal bones, and others. The ideal characteristics of a chelator: high and specific sensitivity iron, high chelating capacity, low metabolic rate, penetration into cells and tissues, low toxicity, low price, can be used orally. We also have a deferopron, feriproxtab, orally active, absorbs quickly during 45 minutes, reaches maximum level, and we usually give 25 mg 3 times a day. Total dose 75 to 100 mg per day. We also have difepron, but it's undesirable side effects. It's like neutropenia, agranulocytosis, headache, arthalgia, arthropathy, nausea, vomiting, abdominal pain, liver dysfunction, zinc deficiency. Also, ICL 670 XJ deferasirox. It's also oral, once daily, high capacity chelates, good migration into tissues, 20 to 30 microgram. Patients patients with beta thalassemia, the only method for radical therapy today is hematopoietic stem cell transplantation. As we know, with the treatment of thalassemia, there are classical treatment methods and modern treatment methods. So the classical transfusion, chelatotherapy, and splenectomy, and for the modern treatment methods is transplantation of bone marrow and prenatal diagnostics. With the transplantation of hematopoietic stem cells, sources of stem cells is bone marrow, peripheral blood, or cord blood. So the transplantation of bone marrow, first successful bone marrow transplant, 14 months old, never received a blood transfusion. And also Lucarelli Pesaro, 1981, 14-year-old patients who received 180 blood transfusions, had a transplanted, ended in rejection transplant. The classification of risk, there are 1, 2, 3 group. The first group is good chelatotherapy. There is no hematomegaly, fibrose, and fibrose. The second group, they maybe have or not have chelatotherapy, and also they maybe have and maybe not have hematological. And the group 3 is absence of chelatotherapy, and etc. I will see the results of Pizarra. Is from 1 to 35 years transplant results. You can see it December 17, 1998 till 2003. This period of time will show 68% of thalassemia-free survival, and also we can see that it is going to increase. The second group, it's also thalassemia-free survival 85%, non-rejected mortality 13%, rejection 3%. And the third results, like it's not, it's 57% of survival, free survival, and survival 74%, but we see here the mortality of 20% and also rejection. And also it's the results of adults, survival 67%, thalassemia-free survival 63%. One brother or sister chance to be fully compatible 25%. Parents family chance of finding a fully compatible donor, it may be 30%. Alternative donors can be haploidentical, not related, full compatible, umbilical cord blood. With the transplantation or cord transplant blood, we have 33 cases, remain 7 cases, and live without thalassemia 79% for 2 years, and we also have chronic case 2 cases. I also would like to show here Jordan. It's also 97% in Jordan, the survival rate, and 88% life without thalassemia. Turkey is very similar results. The 92% survival rate, 82% without thalassemia, and I will show results in Azerbaijan since 2014. Because we also have more diagnosed with thalassemia. So here we can see in 2014 we have 3 rejection, 1 death, and total 9. We started a bit late. In 2015 we had 11 patients, 9 survival rate, 2 rejection. In 2016 we had 9 survival, 1 rejection. In 17 we had 10 patients, 8 survival, 1 rejected, 1 death. In 2018 we have 13 patients, 13 survival rate without thalassemia. 2019 13 without thalassemia, 2 to rejection, to death. In 2020, 14 patients, 13 survival rate, 1 rejected. In 14 patients, 14 without thalassemia. 2022, 26 without thalassemia. 2023, 19 patients, 16 without thalassemia, 1 rejected, to death. In 2024, we have 25 without, and 1 is rejection. So the characteristic of patients, the risk classes of these 95 patients belong to group 2, 28 to first, and 45 to third risk group. And also we had enrollment PMN in fragment day 12, 11 to 18, and PLT in fragment day 18, 12 to 47. Results 168 patients total, 150 patients survived without thalassemia. And also I would like to share about my ablative treatment. It's also according to the class risk, we prescribe a different dose and different different medicine and also different protocols. You can see it now on the slide. Like for the class 3, we also have all the statistics to which group risk patient we used, what kind of treatment, and what we combined it, and in what dosage. So in general, according to the statistics, we know that we use more relatively also made statistics that more survival rate with the combination of with the product, and we even use this with the relative transplantation cases. The acute UVD we had in 32 patients, and also now we have chronic 3 patients, and they still receiving treatment. Around complication, we saw more like it's a mucositis in 61%, and also we see infections, CMV reactivation for 54 patients, and hemorrhagic cystitis 14 patients. And anyone with an HLA compatible donor should undergo BMT for each patient with thalassemia as early as possible. All patients with beta thalassemia should be tested for HLA compatibility with their siblings and parents. And on the picture, you saw our medical staff, personnel. Thank you very much for your attention. If you have any questions, please. First of all, Nargis Hanum, if you can see me or not, it's Eldor. It's very glad to see you. Thank you very much for your wonderful report. I see that you have a huge experience on transplantation for patients with thalassemia. We are doing only first steps, and I think we will worry you on how you lead these patients and sharing just your experience. Thank you very much, and I really honor what you do. We are really waiting for you in Tashkent. Be healthy. Thank you very much. I would really love to help. Nargis, we have one question. Thank you very much, Nargis Hanum, for your presentation. Yes, I have a question. Do you plan using transplantation non-relative? Yes, thank you very much. We plan. We are waiting from the bank of donors because we already started. We opened the bank, and then we will start doing it because we have a lot of patients who really need this transplantation. So not to put it, we are going to do it here. Yes, but the first I plan transplantation for children from parents, and then we will see. And one more question. This moment you have register of donors, and about quantity, do you know, or the quantity? So currently we have around 2,000 right now. It's not much. Hopefully we will start doing this work more intensively. Thank you very much. Thank you very much.
Thank you very much for your performance, and all the best. We have next topic, clinical immunology in practice of the hematologist doctor's practice. And now the floor is given to the doctor, hematologist Kraleva Albina Rustamovna. She is the representative of Scientific Research Center of Pediatric Oncology, Immunology and Hematology. Good morning, everyone. Thank you so much for providing me possibility to have a floor here on this conference. My presentation is about the clinical hematology specialist practice, and this is addition to whatever yesterday Adlat Abdrahimovna mentioned. This is about the primary immune deficiency. This is genetic disease which might affect the development of the function of the immune system. The main aim of this immune deficiency is because of the inheritance comes from the parents, from one of the parents, or it might be spontaneous as well. It might lead to the development of the certain inherited defect. Usually it develops a certain autoimmune disease, oncological disease, inflammation process, or allergic process. In 2019, the International Council of the Immunobiological Societies, they provided the updated version of the classification, which includes the all the congenital mismatches of the immunity, which includes 412 diseases and 407 unique cases. And the disease itself, it's the understanding itself of the congenital mismatches, it uses they use this terminology from 2005. In Uzbekistan, just recently we added the understanding of the primary immune deficiencies. Of course, we have certain problems with the diagnosis, with the NGS, and etc. All of this is in the process of development. In the practice of hematologists, in the last 2-3 years, children with hematological syndromes have begun to frequently come to them after examination. They are diagnosed with primary immunodeficiency. Currently, 25 patients with various type of congenital immune defects are registered with the Republican Central Practical Center for Children's Health and Clinical Institute. I wanted to show the clinical case. This is the patient, 2022, born 2022. She is from Surkhandarya. She has now, clinical diagnosis: primary immunodeficiency, mutation in the FAS, autoimmune lymphoproliferative syndrome. She had hepatosplenomegaly, secondary thrombocytopenia, hemorrhagic syndrome, and complaints upon admission were, according to the mother, weakness, decreased appetite, abdominal enlargement, increased body temperature up to 37 degrees. And they were checked within our facility. We conducted the sequencing, and we revealed the pathogenic FAS gene, which is showing the association to lymphoproliferative syndrome. This is the girl. She had the hepatosplenomegaly with the thrombocytopenia. And after this, there was a leukopenia. And after this lymphadenopathy, we also conducted the myelogram, and she conducted DNA sequences, and it was a heterogeneous condition of the lymphoproliferative syndrome, A subclass. It was shown that this protein, which codes, plays an important role in the physiological regulation of the programmed death of the cells and also creation of the neoplasms within the immune system. The FAS gene, with autosomic type of inheritance, it is connected to the development of immune lymphoproliferative syndrome. We conducted replacement therapy, immunoglobulin 1 gram per kilogram, prevention of infections. Shobas needs to receive the cotrimoxazole. We also try to find immunosuppressive therapy. This is the rapamune 1 milligram, sirolimus orally a day. This is the second boy from 2019. He has the main diagnosis, the primary immunodeficiency, autoinflammatory syndrome associated with proteasome 1R inheritance, He was checked in every doctor, neuropathologist, gastroenterologist, and etc. without any result. And after this, in St. Petersburg, they conducted the investigation, and the diagnosis was made primary immunodeficiency. And they came to us in a very difficult condition. By hemogram that he didn't had certain serious changes. He had certain changes in ultrasound, hepatomegaly, diffuse changes in the liver parenchyma was there, and also a certain type of enlargement of the liver was there. This is the condition of the child. We also conducted the supportive therapy, immunoglobulin prophylactic, we did prophylaxis of the infection. We also gave him bacillitimib. And what are the definitions of what is combining all of these children with the primary immune deficiency? They have quite often infections and etc. And the conclusion, the current diagnosis and proper sequencing will allow to provide to choose the choose the medication and etc. Conducting the supportive therapy with IV immunoglobulin will reduce the progressiveness of the disease, and implementing the sequencing in the status of the diagnosis, of course, it will improve the work of all the doctors. And in future, we are planning to create the different registry on the PIDs. And at the end, I want to show you the video that we discussed about the first girl who has the autolymphoproliferative disease. This is the girl who were not sitting, who were not standing, she has a very big abdomen. And now, parents, they sent, she is dancing, she's walking now. What do I want to say? That if we reveal early detection of the disease and proper medication will, of course, improve the quality of life of the patient and ease the work of the hematologist. Thank you so much for your attention. Questions to Albina Rustamovna? If you allow me. Albina Rustamovna, first of all, I want to thank you. I'm very happy to see you on the stage. Albina Rustamovna is my student, actually. And the question, two cases that you discussed about, those children, are they from relative marriage, the marriage of the relatives? Yes, one was from the marriage consanguinity, and the other one was not, and consanguineous marriages, and that's why we have this amount of patients, and not only those who have immune deficiency, but with different other genetic diseases, unfortunately. Yes, thank you so much. Are there any other questions? Thank you so much for your message. It is very important. I agree with you fully, Mr. Dojasurovich, because we need to stop this kind of marriages, consanguineous marriages, and then the state would not pay a lot of money for development for having these kind of problems. And this is the complex pathology. That's why we need to stop having this kind of marriages, and after this we will control the birth rate. And I have a question. With the help of NGS, you found the medication which is working in those cases. The question is that those medications, they are not registered in Uzbekistan currently. You used it as a therapy of off-label. And due to that, currently, whether there is some kind of work in order to bring them from pharmacological council in order to approve these medications, because these medications are in need for children with the AIDS, but also with the different other pathologies. Those are very expensive medications, but we need to start working on this in order to have a procurement and to have a faster flow of these medications, and children will receive it faster. And the next thing I want to say that those medications should be received by children like a lifetime. Yes, I agree. And of course, this is a burden for the parents as well as for the state. Who is buying those guys these medications? They were checked by the help of our colleague from Moscow, Dima Mrogachev. Thank you so much. You always help us. And these medications were bought by the funds, sponsors funds, and they got the medications. But they need to receive it lifetime, yes. Adalat Ismailovna is conducting the work with hematologists, that there are certain needs, and we write the needs, the list of the needs, and I hope that in near future we will have the procurement of these medications. Thank you and good luck. Thank you. Recently, we applied for the special medication list, which are not registered, but which are procured. We can do fast registration. We applied, and after that, we also gave the needs list through the fund, and we want to procure it in 5-6 months. You will receive that. Thank you so much. And the last question. Maybe this is not a question. I want to thank you for the presentation. After this, we would have a presentation of the Krug Dabra, and I think we need to pay attention to the practice. This is just a bridge among the off-label medication, which might become effective in practice, and we will talk about it. Okay, thank you. We'll pay attention to that. Albina Rustamovna, thank you so much for your work, for your contribution. And you mentioned properly that consanguineous marriages currently, they are having certain issues. Unfortunately, we don't understand why, what is the reason of those kind of unities happening still today. The next topic, the modern aspect of the usage of the plasmapheresis and preparation of the transplantation of the stem cells. So our speaker, he is the PhD, Abdurrahmanova Nigoraz Nizamna.
Good afternoon, dear moderators, dear colleagues. Let me introduce my report, and it's about modern aspect of use of plasmapheresis in preparation of stem cell transplantation. So the modern transplantology is rapidly developing, facing many problems, one of which is the problem of shortage of donor organs. The use of all components of modern transfusion care and hematopoietic stem cell transplantation allows to significantly expand the choice of donor bone marrow transplantation, reduce the likelihood and intensity of various reactions and complications, and as a result prolongs the function of the transplant and the life of the recipient. The use of extracorporeal detoxification aids begins at the stage of preparation of the recipient for transplantation, is an integral part of the transplantation itself, and continues in the post-operative period. Plasmapheresis is an extracorporeal method of blood purification which includes the removal of plasma with circulating toxins, antibodies, and immune complexes. It used in immunopathological conditions and preparations for transplantation, removal of pathological antibodies in autoimmune diseases, reduction in the level of circulating immune complexes, which reduces the effectiveness of transplantation, correction of electrolyte and acid-base balance, an objective preparation of recipients with a positive titer of HLA-PRA antigen using membrane plasmapheresis. And there are three methods of performing plasmapheresis. It's centrifugal, cascade, and membrane. The centrifugal plasmapheresis is a separation of blood into fraction and centrifuge. Cascade has double filtration with removal of high molecular weight proteins, and membrane, blood filtration through spatial membranes. So about the usage of application of therapeutic plasmapheresis in pediatric practice. And we saw some methods, and the general is for in pediatric we use membrane plasmapheresis because it is more mild and it's not aggressive. The membrane plasmapheresis doesn't have any age risks, and the membrane plasmapheresis also it has the meaning that even a newborn baby, they can use the methodic on the filter of Ross, and this method can be used also this method can also be used in premature newborns weighing 700 grams, and since the filling volume of the extracorporeal circuit and plasma filter is only 10 milliliters and the variable volume is from 5 to 20, opportunities are created for using the hardware method even with the infants with unstable hemodynamics. The term child means a patient weighing from 10 to 35 kg. Patients weighing more than 35 kg undergo plasmapheresis in the same way as adults. During the preparation stage of transplantation, there are criteria, and HLA typing is it should be again, and also there are PRA antibodies, and they also have great meaning during transplantation. And HLA typing is a critical step in assessing the immune status of patients with elevated levels of PRA antibodies, as it allows determining the degree of sensitization to antigens of the major histocompatibility complex. Elevated PRA values indicate the presence of high antibody titers, which may indicate an increased risk of immune response during transplantation, including potential rejection of stem cells used in regenerative medicine. The gene responsible for the expression of the corresponding antigens plays a key role in modulating the immune response, influencing both the development of autoimmune processes and the outcome of transplant interventions. And the study of PRA antibodies allows for the optimization of donor material selection and the development of individualized immunosuppressive therapy regimens, which ultimately contributes to improved clinical outcomes in transplantation and stem cell therapy. In the Scientific and Practical Center of Children's Oncology, Hematology, and Immunology, to assess the effectiveness of plasmapheresis in children with oncohematological diseases in preparation for transplantation, extracorporeal elimination of PRA antigens was performed in 90 children weighing from 10 to 35 kg. The studies were conducted in the period of December 2024 till February 2025. The studies were conducted. The 19 children examined had a positive HLA-DR PRA antigen, and they were divided into 3 groups. 9 children they have PRA antigen 25 to 30%, 6 children PRA antigen 31 to 40%, and for children, PRA antigen 45 to 55%. Patients with titer values above 65% were not included in the study group, and therefore they were not taken as potential donor-recipient pairs. Conducting plasmapheresis on the patients being examined. The procedure was performed in the Department of Transfusiology, Procurement, Processing, and Storage of Hematologic stem cells, blood and stem cell bank. The attending physician from the department where the patient was hospitalized and specialists from the transplant department participated in this process. All patients with an increased titer of PRA antigen underwent membrane plasmapheresis from 3 to 5 sessions to reduce PRA titers. During one procedure, plasma exfusion was from 600 to 800 milli. The number of sessions depended on the level of indicators of the previously conducted test, PRA antigen test. After plasmapheresis, we had a protocol, and the protocol is not only about plasmapheresis, it's also target therapy. The first day it was plasmapheresis. The next day we had target therapy, rituximab, and the next day we had intravenous immunoglobulin, Altragan, and we we the plasmapheresis is only eliminate peripheral peri-antigen, and on the cell level the expression, of course, without target therapy we cannot suppress them. And our doctors, they carried out target therapy. So conclusions. Thus, based on the above, it can be said with confidence that the use of the volume plasmapheresis method in the complex preparation of recipients with a positive titer of peri-antigens reduces the titer to levels to the level of negative peri-antigen that allow transplantation to be performed. This allows the recipient to subsequently ensure effective engraftment of these stem cells. In the presence of anti-leukocyte antibodies in recipients with allogenic transplants, the use of therapeutic plasmapheresis is effective, which must be carried out together with drug immunosuppression until complete elimination of anti-HLA PRA antibodies before transplantation. The use of plasmapheresis is one of the methods of complex transfusion assistance in therapy with the aim of eliminating anti-group and anti-HLA antibodies. Allows us to further expand the boundaries of carrying out this transplantation of the stem cells, namely expand the possibilities of choosing a donor. Plasmapheresis, a key method of preparing patients for transplantation, allowing to reduce risks of further complications. And further research is needed to optimize protocols and improve outcomes both before and after transplantation. I would like to share gratitude to our team. They helped me to do this procedure. Thank you very much for your attention.
Nigora
Nizamovna, thank you very much. If you have any questions or comments, please. If you have any questions, go ahead. Thank you very much. Let's move. And we have the next topic. And it is the experience in using method cell therapy and hemocorrection in Kazakhstan. Amanov Ardak Hamitovich, transfusiologist from Kazakhstan. Please, the floor is yours. Hello again, dear colleagues. Thank you very much for organizing this conference and to really share our experience. And the topic of my report is experience in the application of cell therapy and hemocorrection methods in Kazakhstan. As I previously said in my greeting speech, the development in connection with the development of domestic healthcare, especially transplantology, cellular organ, the blood service faced the issue of improving transfusion support, including the introduction of cell therapy and hemocorrection methods to eliminate patient complications in the pre and post transplantant periods. And the first service we made, I would like to stop at the it is ECP extracorporophoresis, and the Professor Anderson actually offered these methods in 1988, and it was modified into the molecular therapy. And in 1995, FDA approved this methodology, and I will talk more about recommendation. An international Soviet on transplantation of heart and lungs. They said the two sessions which were done in the group before the transplantation of heart, it gives 50% better results for the patients who, in comparison with the patients who didn't do this preparation. There are some modification of this procedure. There are online. It was the apparatus. It's equipment from USA, and also there is a methodology of offline, and it's like separately collected. Collection of mononuclear cells by some devices. The second stage, photochemical treatment of cell suspension with using we do 8-methoxyproserolene, and the third stage, reinfusion of treated cells to the patient. So we went according to the second way. It was offline, and we also made the collection of mononuclear cells. The Teluma, the seventh generation, nothing was like better during the last 7 years. And the photochemical, this treatment is a French equipment, Macagenic G2. It's a French equipment. It's a second generation of equipment. So the mechanism of working of this, the psoralen molecule resembles in structure a pair of complementary DNA bases. Such spatial organization facilitates intercalation of the psoralen molecule between them. So you can see it if I will show you the scheme. So to really to really have implantation and tying, we need this UV irradiation, and we need this A length, 320 to 400 nm. And when we have this tying, then the process of replication of DNA is being disrupted, and then the cell is going to apoptose. In the Republic of Kazakhstan, this technique was first introduced in 2018 at the Scientific and Production Center for Transphysiology, and it is the main center in Kazakhstan, and it was on May 18. In 2019, the extracorporeal photophoresis underwent a medical technology assessment at the Republican Center for Healthcare Development, and purpose of use was treatment of hormone-resistant forms of the stem cells after this. It was a second protocol line of treatment for stem cell transplantation. And also in the Center of Mother and Child in 2022, extracorporeal photophoresis was included in the treatment protocol for Crohn's disease in children. So on this slide we can see the number of sessions in 19 oncohematologists. They were still watching closely what we are doing, and you see in 2022, like we know, because of the event we had and the all of this stuff, we had only 16 sessions, and we also had this sessions of and to have this need, and we also have this oncohematologist, to have the patients who really need. And in 2023, we really decided the tablets, the pellets, photosynthesizers, and it gave us the actually save cost to 50%. In order to use on children, we need to have experience with adults, and in 2023, for the first time, with the autoimmune system, with vitiligo, we had also patients, teenager with vitiligo, and at the end of 2023, we have a patient with the disease of steel. It was after COVID, and we see this actually growth of autoimmune disorders in Kazakhstan. It's I will say it's usually 40+, and all of them they carried the COVID in a very easy form, and we had this. And we had this a lot of cases with autoimmune disorders, and we had two sessions with this cascade. And the second stage, we did 6 sessions of electrophoresis. And I will say that still today we are in connection with this patient, and she is in remission stage. And after that, we started to apply it for children. The KPH, the fourth stage, and 2024 we see the necessity is there, and actually during 1 month we already had 3 patients who went 9 sessions, and it was patients with the hemorrhagical cystitis after gallbladder tissue transplantation, and literally after 2 sessions they really became better and the hematury stopped. So total it was 4 sessions. Another one, he was with the chronic skin disease, and to reduce this dosage of immunosuppressive therapy, and this patient with one chronic problems with digestive system, and the patient the brand he has this immunosuppressive therapy, he had some septic condition. We had to conclude this, and we need to we will do this after the rest. And also we saw this problem, the problem with the expenses. It's the high cost of medical supplies, and we have the solution. It's cost reduction, introduction of the mini ECP method plus irradiation on the KIT device using tablet forms of photosensitizers, and they developed the third apparat kit A, or equipment kit A, and they also started to use tablet forms of photosensitizer, and it's like Russia production. And also to save or to reduce the cost for adults, we also do the method mini CP on the 7th Congress of Transpheresis. It was suggested by Austrian colleague, and it was good results and not really big differences, and our colleagues are satisfied, and we have good results with this other decision. So at the end, I would like to show 3 cases, it's our first patients. It was 2018. It's a adult. She was 35 years old, and she has acute lymphoblastic leukemia and condition after related halo, and she had a very bad case with her skin, and she had this treatment, and during 2 weeks you can see the result. You can after that our oncohematologist colleagues offer it, and we see the results after 3 sessions. And after 3 sessions, we already can see that almost 70% they were gone. The skin became clean, and the colleagues of oncohematologists started to reduce immune suppressive therapy. And the this patient got 8 sessions, and to the end of the treatment, she was really off from prednisolone. And on this picture we can see this immune memory. We saw this immune memory, and we saw it in the literature, but we didn't really get it how it is actually in life. And she is not from Almaty, she is from another country. And on the background, this patient, she had this irritated skin, and the dosage hormones was 10 milli during 10 days, and it was this irritated skin was gone. And this was she was 2 years. It's a 2 years patient. She also had acute myeloblastic leukemia condition after related halo. Her mother was her donor, and she had this also chronic disease, cutaneous form. From the left side, we can see what was before the treatment, and she is a child, and we just make a photo of only the right ankle, but she had it all over the body. And after 4 sessions of autophoresis, we can see it here after. We can see the results after 12 sessions, and after that we give these patients to the hematologist, and we saw that it was the reduction of immune suppressive therapy in twice. This patient also went therapy in 2014. It also acute myeloblastic leukemia condition also after the haplo, and here it's also a chronic RDPH. It's also we saw this after even one session. We already had results, and he got 2 mg per 1 kg without effect during 10 days. So then our oncohematologists, they came to us, and during 1 month he got 8 sessions, and during this time the immune suppressive therapy was reduced by 4 times. The second service I would like to talk in the previous also presentation we saw it in the double filtration. We call it cascade plasma filtration, and we actually were interested in this methodic. We thought that in this photopheresis we do this Kazakhstan, and it was oncohematologist, and autoimmune system is about having the autoimmune complexes, and the first stage, as I already said, the patients with the still disease, we did 2 sessions of cascade plasma filtration. What is it about? So it is a high technology selective method that allows selective removal of pathogenic target components from blood plasma while preserving beneficial elements, and scope of application is neurology, and I can say cardiology, and I will say it like at the beginning when we start to use this application, and all autoimmune disorders we had, it was this photo. It's our result. Let us see from the left to the right. I state unique Japanese fractionator of plasma, and the cascade Evoflux, they were identical, one manufacturer, and during one procedure the targets is from 0.8, it's till 1.5. Roughly, we can say we can go through this plasma separator. In the middle, we can see plasma which is already cleansed, and it goes to the patient to the left side. It's a simple. It's just for cleansing the plasma. So it's a filtrate which remove, and it is going from the patient's plasma, and this patient is a teenager in this case with Crohn's disease, and he has titers antibodies Kalibomagi 1 to 150 and 1 to 10. So you can see from 15 dosage of antibodies, and it's a refractory form. Which allows us to remove these antibodies, and then gastroenterologists and pediatricians, they go back to the same treatment, and they can see the effectiveness. So what we have by this method, it allows us to really have the selective removal of the pathogenic target component from the entire volume of the patient's plasma, and accordingly a significant decrease in its level in the blood. Of course, we can see the improved microcirculation in blood. Rheology, we also see, we can see it. Also minimize the loss of albumin and other biological factor usefulness, because we don't remove the plasma, but we just cleanse the plasma, and we give it back to the patient, and that's why we have reduced the need for the use of expensive plasma substituting solutions, and significantly reduce the dose of medications. So it's cleansing of receptors, and also achieve rapid recovery of stable remission of the disease against the background of adequate basic therapy, and minimize the likelihood of developing various complications of the underlying diseases, and practically reduce the risk of allergic reactions and infections of the patient. In the Republic of Kazakhstan, this technique was first introduced in 2020 at the Scientific and Production Center of Transfusiology. In 2021, cascade plasma filtration was assessed as a medical technology at the Republican Center for Healthcare Development. Initiators was transplantanologists of the National Scientific Oncology Center, and the purpose of use was preparation of patients for upcoming solid organ transplantation with a high titer of anti-lymphocyte antibodies, and also treatment chronic rejection syndromes or post-transplantation period. And also, as I said, it's now in the protocol for the treatment of Crohn's disease in children. Now we can see the number of patients and procedure. 2022 was breakthrough year for us, because we opened the cabinet in the Center of Mother and Child, and we started to work with kids with autoimmune disorders, and it's like infections of the digestive system. When we also opened under the Republican Genetical Center the cabinet of hemocorrection, so we can do these procedures for adults. In 2023, it was a high, of course, but according to the events we had with Russia, and we had some logistics problem according to the difficult situation which are happening in chemopolitical world. So but still we are doing it even in 2025. We already had 5 sessions of cascade therapy, which I already mentioned. And also, according to the slide, I would like to say that we had experience of using, like it was in February actually, we had a selective plasma separation Everclear to the patient with a hyperbilirubinemia, and she had plasma exchange sessions. And I would like to say that the results we already received the same. Every session is giving reduction of bilirubin twice, and we also don't have risks for development allosensibilization, because we use the plasma replacement. And we also don't have risks for giving transmissive infections. So if in comparison with plasma exchange and selective plasma filtration, then obviously me and my colleagues, not only in Kazakhstan but also abroad, and it's like we really agree and go to the conclusion to use specific Colonox is more safe for the patient. So it's my personal position. So the problem I said already that the lack of sufficient number of plasma separators in Kazakhstan, and the solution was the registration in the Republic of Kazakhstan, import in the country directly from the country of manufacture. It was Japan, and now we go from directly because they are manufacturer, and now we have it in Kazakhstan. I also would like to show you this slide. It's at the beginning started the usage is almost all our specialists. The biggest, I would say, the actively we use it's cardiology. It's hyper. And among 23, we had 2 teenagers with genetic disorders, and it's like family hypercholesterolemia, and she's 13 years old girl, and she had this genetic disease, and she it is results after first session, and she had 3 cycles per 2 sessions per cycle, and the difference between sessions like 3-4 days, and firstly we had her total cholesterol, it was almost 80, and after the first we can see it like this was 95% result of effectiveness, and you can see the results on the slide, and we had only two sessions so far, and it was also good results with biochemical blood test results improved, and all these numbers came back to normal, and we can say that these patients they have this family hypercholesterolemia, and they need this on a regular basis. And this patient is only 13 years old, but already she had problems with very very bad blood analysis, and if the use of HLIPOFRS, it allows, like with a long usage during 1 or 1.5 years, it gives regress, atherosclerosis, and the next patient is also teenager with the Crohn's disease on the biological therapy, and therapy was called adalimumab, and it was maintenance course. 2 sessions of cascade plasma filtration were performed, 1 to 5 and 1.0 with the volume, and calciprotectin. It's not going like very fast. We really take 3 to 4 weeks like to really track the dynamics, and then he went back to eastern part of Kazakhstan, and the colleagues they showed the results. The results that it went to normal rates, and now we have 20 patients with Crohn's disease who had antibodies to biotherapy. Now they also went through cascade plasma filtration. And another young man, 29 years old, and the diagnosis hyperlipidemia, and it's also genetical disease, and his father is having diabetics, and we can see here on the slide also before the cascade plasma filtration and after. The results are really impressive, and there were problems with insulin as well. After one session, we can see how it is becoming normal. I also would like to share about our further plans. Yesterday I saw a presentation from a Belarus colleague about CAR T cell therapy application in Belarus, and even our one patient is in Belarus now, and he is going to undergo CAR T cell therapy, and now we have scientific program. And we started actually since the end of last year the financing of this program, and I hope that in 2026 we start to use CAR T cell therapy for the first patients in Kazakhstan. What is it? It's chimeric antigen receptor. It is an artificially created T lymphocyte receptor through which this immune cell, when interacting with cancer cell, recognizes it activates it, and destroys it. There is also methodics in 3 stages, and the first stage is collection of autologous mononuclear cells, and I would like to draw your attention. We also do this on the spectrum equipment, because the quality of these cells is the foundation for doing this CAR T therapy, and we will have at the end very good product and good result. Then the next stage is it is a transfusion of autologous lymphocyte using chimeric antigen, and then it is going to our specialist, and they have Limax Prodigy equipment. It is needed to do this transduction of this lymphocyte with using a chimeric antigen, and the last stage is reinfusion of the obtained cells to the patient. And so this type of treatment, it is actually combined 3 modern methods of treating cancer patients. The patient is going it's cellular. The patient receives not a chemical substance but a live drug in the form of improved cells from his own body. The active substance of the administered drug is modified T lymphocytes, which perform the function of immune defense by recognizing foreign substances, in this case cells of multiple myeloma, leukemia, or other types of cancer, and neutralizing them. and gene lymphocytes are not used in their natural form, but rather those that have undergone genetic modification in a certain way, trained to recognize a tumor and act on it. So, the conclusion, it is since 2013 the purpose of our work is all methods must be made available, chemocorrection and cell therapy for the population of Kazakhstan within the framework of the state fund for free medical care and compulsory medical insurance. So that's it from my side. Thank you very much for your attention. If you have any questions, please go ahead.
We want to thank Yurta Kharimidovich. It's a very interesting, insightful presentation. I received a lot of information for myself. That means that psoralen, it is used in combination with ultraviolet radiation, which will cause lymphodepletion in the difficult forms, in the severe forms of this disease. Did I understand it right? A photosensibilizer, it will improve the absorption, and it will enter the DNA, and within the electronic condition, it will affect the replication, and this pathological clone of leukocytes, they will not be attacking, and we can see that there would be a clinical improvement. And if this lymphocyte is not attacking, and it will not consist of the pro-inflammatory cytokines within it, and it will not go to plasma, and it will not continuously cause the acuteness of the inflammation process later. And I also want to say that in autoimmune disease, Professor, he proposed after the photopheresis to conduct the transimmunization to affect the pro-inflammatory cytokines. And the 7th Congress was in 2021 in Dresden. And his presentation was at the first place. The first topic was transimmunization in patients with the multiple sclerosis. But in general, the information point, psoralen, first of all, was revealed many years in Tashkent Medical University, actually. This is for just a development. Thank you so much. If you have very short questions, then you can ask. Otherwise, we are late. Thank you so much. The question is not, I cannot hear the question. She needs to speak to the microphone. As far as I understood, the amount of causes and clinical recommendations, right? Yes. We understand that every case is individual. If we will, like 1 year ago, Professor Anderson, he conducted a consensus meeting on photopheresis, and he raised the question from the history saying that they proposed this method in 1987 to treat the severe lymphoma, malignant lymphoma. And currently, American Soviet of this societies, they provide the recommendations in autoimmune disease. And Professor raised the question that we need to define the oncological and autoimmune patients. And for this, what is important, operator, at the beginning, for example, we need to decrease the immunity, and after that, we can stimulate it to medications which are used for about 30 years. It's an American and French one. Those are analogous of this medication, and they don't, unfortunately, have this possibility. And after Professor Khidishevsky, he is an author of this equipment, and it might affect the length of the wave. But here we need to understand what is the picture. that those two diseases, if it's in acute stage and chronic stage, there's a different approach needed for that. In the acute one, we need less courses of treatment, but at the same time, we need to understand that this is not like a widely used treatment, and the best results, of course, is reached in 82% of patients who received pastapheresis, they respond to this therapy. If we will look to the intestinal form, then it's 68% in the liver, 54% in the lungs less. This is not the mass medication treatment, but we need to use it anyway because there are certain patients which are not responding to the traditional therapy, and sometimes patients, they say, we did everything, but nothing helps. And that's why, and in addition to that, this immune memory citrons. If autoimmune disease patients, he receive photopheresis courses, he will, of course, has certain symptoms to be raised. But the next exacerbation of the symptoms will be less clinically significant. That's why they will develop the immune memory. Okay, we want to thank our guest, and we will continue by plan. Our next topic, our first experience of PHP status in carcinoma of the pharynx. And the floor is given to Madam Mina Fahmat Yildashevich. He's a professor of pediatric oncology, hematology, and immunology. Good day, everyone. In particular, the guests who came from far and from different countries, from neighboring countries, from Russian Federation. When we talk about the squamous cell carcinoma, which is associated of the human papillomaviruses, this is revealed quite often in the teenage age, as well as in young, as well as in adults. Why we need to reveal the persistence of this virus, of papillomavirus? It is important within the nasopharynx and oropharynx by the statistical information of the spreading of the cancer. Uzbekistan is also having significant data about that, and the structure of the disease consists of 14% of the primary revealed patients. HPV is spread among the patients who has the oropharynx cancer. We should have to say that lower in the indices in the Asian countries, it would be explained by saying that the diagnostic methods are not used quite commonly in order to reveal it. And in US, in 70% of cases, they reveal the persistency of the HPV of high risk of patients who have the oropharyngeal cancer. In 2008, German virologist Dr. Karl Surhasel, he became the Nobel awardee in physiology, and he found the physiology of papillomavirus. There are different 16 genotypes of this HPV virus existing. HPV virus, by classification of International Agency of the Cancer Investigation, is considered to be the first group cancerogen. In the 8th edition on UICC, the cancer, oropharyngeal cancer, it is divided into subgroups based on the status of the HPV. The most important thing is that positive P16, it will considerably reduce the disease stage, and based on the classification of the head and neck cancer, the international organization, they also divided to HPV positive and HPV negative ones by the Center on the for Disease Control and Prevention, and it is found that it's epidemiology. This is the most common epidemiological type of the cancer, which will be revealed after the HPV is spread. And this scientific work is conducted with the next aim to study the molecular biology of biological characteristics of squamous cell carcinoma of the oropharynx by immunohistochemical assessment, expression of proteins, this p53, depending on the HPV status. This is the scheme, this is the design of investigation. The scientific work was conducted in the National Scientific Practical Center of Pediatric Oncology, Republican Scientific Center, in order to reveal the immunohistochemical as markers, PDL1, P16, P53, which is fixed by formalin and paraffin, samples are in paraffin, and after this we reveal the which is status of certain category. If more than if there is a high intensity dying that can be seen, then it will be considered as a HPV positive patient. And the expression of the PDL1 was assessed based on certain methods. Here you can see different types of the dying of this immunohistochemical dying with the different types of this HPV, such as mutant version, or it might be the wild type, and also mutagenic type, and etc. It will here, based on the histochemical analysis, it is difficult to find out certain things because it's difficult to reveal whether it's consists of degradation or deletion type of mutation. That's why we propose the method of analysis of histochemistry, which is based on the co-expression of the protein P16 when it's positive. In this case, the full loss of expression is related to the dehydration, protection of dehydration of the HPV protein. And if there is loss of P16, then it might be connected to nonsense mutations, deletions, and frame shifts. Within the investigation, we created the interval scale in order to assess the expression of certain markers. Currently, international practice use different methods in order to detect the persistence of the virus, but here you can see that from immunohistochemical analysis of P16 up to RNA sequencing, the specificity is raising, but we should have to pay attention to that the DNA PCR can also reveal transitory infection. That's why when we use those methods to reveal the HPV infection in the squamous cell carcinoma, we need to pay attention to that. DNA PCR can reveal certain intraoral infection in addition to the HPV. Here are the cases. This is the first HPV positive squamous cell carcinoma, which is revealed, and there is a high expression of the protein P16. And in the second micro image, there's a loss of a positive expression of P16. Here you can see different intensity of expression, protein PDL1. This is the first loss of expression, and etc. The more intense in the expression is connected to the infiltration of the effector T lymphocytes, although the cause by which the receptors of PD-L1 were not revealed in stroma, it's related to that fact that there is no onco cells which are keeping PD-L1 on their membrane, and antigen presenting cells which consist of PD-L1. In many cases, they propose their new antigen in the lymphatic nodes mainly. This is the full. This is the mutated version as well as the wild version of this P53. It can provoke the oncosuppression of PP53, and after degradation of these imported oncosuppressors, there would be aberrant development of the cycle, and it will itself stimulate the certain receptors, and it will be the biomarker in order to put the status of the HPV virus within the person. But due to the fact of the suppressor proteins, it will lead to the invasive cancer's development. In our investigation, patients were divided into two groups. The first group consists of 28 patients with HPV positive status, and the second one, they had 36 patients with HPV negative status. These are the gender differences based on which we can see that the men, they have certain a little bit highly revealed cases of HPV. In 93% of patients who were positive, they had tonsilary cancers, and HPV negatives, they had non-tonsilary type of cancers, which are not consisting of lymphoid tissues. Here you can see P16 negative squamous cell carcinoma, as well as the left palatal, tonsilary palatal membrane cancer. And when we put the staging by the system of TNM V8, it helped us to reveal up to 93% of the early stages of the cancer, the spreading on by the groups of this mutated protein. It was revealed in 80% of cases, because in HPV positive groups, the activity of this protein was not revealed. And this is considered to be the positive group. When based on the expression level of PD-L1, the low levels were in the positive groups, and if the PD-L were high, then in HPV negative groups, they had seen this protein within it. The mutated version of the protein P53. In many cases, it was HPV negative. The wild version P53, the low level or the middle level was seen in the HPV positive status. In addition to that, we conducted a correlation by Pearson among the molecular markers on HPV status. As a result, we revealed that among this PD-L1 and HPV status, there is no interconnection, and among this mutated version, there is an HPV status, there was a high correlation. And in addition to that, we conducted the assessment of the objective response to the treatment based on the status of the HPV status, as well as expression of these molecular markers. Here you can see the patient 16-year-old. Based on the computed tomography locally, you can reveal here the P16 positive squamous cell carcinoma of the soft palate, and this is after the full course of chemo and radiotherapy. This is the full objective response after the treatment received here. In addition to that, we studied the general overall survival rate based on the Kaplan-Meier. We were calculated based on which HPV positive patients, they had very long survival rate in comparison to the other ones. This is the overall survival rate based on the PDL1 as well as the P53 mutated version of the HPV. And here you can see the survival rate. This is HPV negative group, and before it was negative HPV positive group. The average survival rate in patients by levels of expression of PDL1 and P53. The regression was done based on the Cox method. The positive HPV status is seen more in the rare wild type of the mutation, and mutation of the P53 marker, it will negatively affect and it will in 8 times improve the increase the lethality cases. And we integrated the prognostic model in order to by using the logistical regression in order to assess the quality of the model on the next interval scale. If it starts from 0, 1 then to 1, then it's considered to be the good quality prognostic model. And prognostic model is built based on the clinical demographic model. It had wonderful prognostic value and the results were statistically significant. And at the end, I want to mention that revealing and persistency of the HPV and specific molecular biological character of these tumor cells was developed by certain markers which consist of PDL1, P53, as wild type as well as the mutated version. In general, I want to say that tumors which has good variation of expression of the molecular markers, they show the ideal group to escalate the treatment. Escalation, it means the first configuration variation of the expression of these markers can be programmed by the de-escalation program in order to reduce the aggressive method of treatment in teenagers and in young adults. Those are the main HPV negative patients. And the second category is the bad category with the expression of molecular markers. They demonstrate the other type of result and mainly the HPV negative result patients. And knowing the sequencing of the L1 gene as well as the molecular structure of the HPV virus has a significant impact to develop that vaccine at the end. One of the 12 possibilities to reduce the cancer, which is proposed by the WHO, is the 11th point is considered to be the most important part. This includes the vaccination among we girls to vaccinate against the HPV virus. Regarding the vaccination of the HPV in the international practice, there are 3 types of programs implemented: early, the second one in the teenage age, and the third one up to 45-year-old. And there are 3 types of vaccination: Gardasil, Cervarix, and monovalent type of vaccine exists in the world. And shortly, I want to stop on the future investigation, which is for the effective treatment and prophylaxis of the pediatric cancer, and it will be more. It will integrate new generation of sequencing, one cell type of sequence, DNA sequencing, in order to reveal the genes among the microenvironment of the tumors, bioinformatics, system biology, and etc., as well as for the AI. At this point, I want to stop with my speech. Our main goal is for the safety of children. We want to thank you, of course. We want to thank our respected, honored speaker. We want to thank you, and we wish you all the best. Very interesting presentation. Thank you. And in reality, yes, we are seeing that in our country, in this sphere, such a kind of development happening, and we know about all these facts from the presentations of today, and we hope that we will reach higher results. And the next presenter is Denikina Yulia Varievna. She is the head of the Department of the National Medical Research Center, named after Almazov in Russian Federation, and she will be in online format with us. And now, please pay attention to the screen.
Dear colleagues, good afternoon. I am very pleased to welcome you and thank you very much for the opportunity to share our experience today, managing such a complex category of patients as children with neurofibromatosis type 1, and first and foremost with an emphasis certainly that neurofibromatosis is genetic is caused by mutation in the NF1 gene. Indeed, it was described quite a long time ago, but I'd like to know that the gene itself was identified in 1990. The disease belongs to the group of Russell-Patterson and follows an autosomal dominant inheritance pattern with 100% penetrance of the trait, meaning that any patient with the mutation will inevitably exhibit the either typical or atypical manifestation of the diseases. It should be noted that this disease is characterized by an extremely high frequency of spontaneous mutations, accounting for more than 50% of cases. This indicates that a child with neurofibromatosis type 1 can be born even completely healthy parents. And of course, for us as oncologists, this disease is of particular interest and importance because it belongs to the group of cancer predisposition syndrome. The NF1 gene mutation plays a very significant role in the development of tumors. So these patients undoubtedly require very close dynamic monitoring throughout their lives. The issue of awareness about orphan diseases, including neurofibromatosis type 1, is highly relevant today. Speaking of Russia, statistical data shows that, in fact, the majority of Russians have never heard of orphan diseases in general, and only 15% have heard of neurofibromatosis type 1. This is truly unfortunate and indicates that we need to raise awareness about this disease, and not only among specialized professionals in our community, but also by promoting it through mass media in some way, so that patients can socialize, understand the possibility of receiving help for this condition, and somehow contribute to improving their quality of life. I will briefly draw your attention once again to the fact that the pathogenesis of neurofibromatosis type 1 lies in a mutation occurring in the NF1 gene. As a result, the production of the protein neurofibromatin is disrupted, which is a key participant in the process of control over the activity of cells in our body, specifically in processes such as proliferation, growth, and lifespan. If these processes are disrupted in one way or another, it leads to the clinical manifestations of the disease, which I will discuss. It should be noted that the neurofibromatosis type 1 is a very unique condition. In fact, it is very difficult for us to predict how it will progress in a specific patient. We can say with certainty that 50%, some patients may never seek medical attention and will have only mild manifestations of the disease. But unfortunately, in 20% of patients, there can be severe complications that require medical intervention. These include both tumor-related and non-tumor-related conditions. However, it should be noted that as a rule, this particular category of patients will experience disability and a significant decline in quality of life. Therefore, our task in any case for any patient diagnosed with this syndrome is to monitor neurofibromatosis type 1 throughout the patient's lifetime, tracking conditions associated with the disease through regular specialist examinations, utilizing necessary diagnostic methods, and applying our available treatment options whenever necessary. But first, I want to emphasize that the clinical manifestations of neurofibromatosis type 1 are extremely diverse. Many of them you're undoubtedly familiar with, and the most common one is skin involvement. We have all heard of conditions such as Kefauver spots and cutaneous nephropibromas. These actually represent a pronounced cosmetic defect, and essentially specialists of any field may notice them. And often this serves as a reason for further diagnostic evaluation. In addition to skin involvement, there are various functional impairments affecting completely different organs and systems. Here it's important to highlight cognitive impairments, recurring headaches, seizure syndromes, and essential arterial hypertension syndromes, and essential there are endocrine disorders. And of course, it's very important to know that cause severe disability in patients and various musculoskeletal disorders, including severe sclerotic deformities of the spine, the formation of pseudoarthrosis, frequent bone fractures, and a number of congenital disease conditions. Bone pathologies and other related issues undoubtedly serve as a reason for seeking medical attention. But among this vast variety of different clinical manifestations, it should be noted that the diagnostic criteria for neurofibromatosis type 1 have been established on a specific clinical manifestation have been defined. Here they are presented in the table. Quite briefly, this is international consensus that is actively used today. And if we understand these criteria, regardless of their specialty, will be able to make this diagnosis based on the existing clinical manifestations. If we take a child born to healthy parents with no genetic predisposition, but who has Kefauver spots, know that they must have certain number and size depending on age, and for example, plexiform neuropathy on optic nerve glimmers, and based solely on clinical manifestations, we already have the right to make this diagnosis. And if the criteria are not met, meaning we do not have two criteria, then of course molecular genetic testing can be helpful. But I would still like to point out that unfortunately it's not always possible to confirm this mutation in all patients. These are cases where clinical criteria are present, but genetic testing comes back. It comes back negative, but this doesn't rule out the diagnosis. Once again, it's very important to remember that neurofibromatosis is an entirely clinical diagnosis. If we can establish the diagnosis based on the criteria, you can do so with complete confidence. However, in cases where neurofibromatosis is diagnosed in children born to parents who already have a confirmed diagnosis of type 1, the presence of just one criteria is sufficient, which in a way simplifies the entire diagnostic process. It's very important to remember that type neurofibromatosis has what is known as an age-dependent onset of symptoms. In other words, we understand that the child is never born with all the clinical manifestation required for diagnosis. These manifestations will appear and worsen with age as the child grows, and this will certainly happen to everyone. But as you can see, the frequency, in fact, the occurrence of various clinical manifestations is quite high. It often happens that a newborn baby has no clinical manifestations at all. By the age of 1, 2, or 3, a number of signs accumulate, allowing us to make this diagnosis. A very interesting question concerns the existing correlations between genotype and phenotype in diseases. Scientists continue to study different variants of the NF1 gene and compare them with clinical manifestations in order to potentially predict the course of the disease for each individual patient in the future. However, I want to point out that as of today, there is a very little data on this. Here I have presented to you a number of genetic that are associated with specific clinical presentations, but to say that we can use this in routine practice just like that, there is no use for it today. For now, this remains more of a scientific interest rather than a practical application. Once again, I want to emphasize that patients with nephrofibromatosis type 1 do indeed have an increased risk of developing tumor-related diseases. Here, various types are presented, including benign tumors, plexiform nephrofibromatosis, which we will discuss, and preterm more such cases and occur in children, adolescents, and adults, including hematologic malignancies, as well as breast cancer and several other conditions in adults. And in fact, this knowledge a doctor who plan to monitor these patients must be informed about the lifetime risks, the development of specific tumors, and their frequency in order to offer the best care to the patient. This includes specific timelines for clinical monitoring. According to the international guidelines, we can clearly state that, therefore, monitoring necessary for children and the risk of tumor development increase, gliomas of optic pathway gliomas, and slightly less frequently for adults, despite the increasing risk of malignant neoplasm. Nevertheless, the frequency decreases to some extent with age. I want to emphasize that oncological disease in patients with type 1 nephropathy will reduce their life expectancy, and you can see here we have presented curves from a large international study which clearly shows that the development of a malignant tumor statistically significantly reduces the life expectancy of these patients. Depending on the time of tumor, the curves will also vary. You can see the worst outcomes are observed in cases of highly malignant, poorly differentiated sarcomas and several other types tumors. I have mentioned the specifics of monitoring these patients. First and foremost, it's timely verification of the diagnosis, ideally at an early childhood age. This is monitoring of all the concomitant diseases that I mentioned, and it could be orthopedic pathology, it could be a pediatrician who will treat, I don't know, from arterial hypertension, some conditions could be oncologist if the patient primarily suffers from tumor-related diseases. In addition, we must, of course, strive to predict the risks that a specific patient may have, certain clinical manifestation, and of course, oncological vigilance is essential. We must be very attentive when transitioning our pediatric patient into the adult healthcare system, ensuring that all existing recommendations and diagnosed conditions are properly conveyed. Additionally, we must determine the strategy for further screening and monitoring, provide guidance to our colleagues, and most importantly, fully inform our patient. Here is a very important question. What and when should we treat? We understand that the nephrofibromatosis is a genetic disorder. Today it's not curable, and if we today we discuss plexiform neurofibroma and the available treatment options specifically for this time. Now I will share with you the model of care should be provided to patients with type nephrofibromatosis and how it's organized in our clinic. We have a patient who is undoubtedly surrounded by the attentions of specialists from various fields due to the diverse clinical manifestations of the condition, but there must always be a specialist, so-called coordinator. In our case, a pediatric oncologist who provides continuous monitoring of the patient. They plan the necessary scope of examinations, ensure access to all treatment options, pediatric resources, and so on. They stay in contrast with all specialists, including narrow field experts, and involve them when necessary. And of course, we have the option of telemedicine consultations. This means that patients from different clinics can receive remote consultations from our federal center or other federal centers in our country, where they will get an expert opinion from specialists, possibly a plan for the necessary scope of examinations and treatment. And I want to emphasize once again how important it is ongoing educational events, close interaction with patients and organizations, and the dissemination of information through mass media. And here I just want to show you an example. We actually write a lot of nephrofibromatosis type 1, and this has already yielded results and successes. This truly helps patients stay informed and know where to seek medical assistance. We write about this in some medical publications. We write about it on websites across various channels, but really I want to emphasize this. It's absolutely necessary, and it greatly helps our patients in many ways. Now, just a few more words about tumor disease monitoring. I think you can follow the link. and take a closer look at the publication. It truly contains all the recommendations based on the patient's age and the necessary examinations. But I want to draw your attention to something, and this is constantly emphasized by the international community of specialists. Clinical observation is truly of utmost importance. First and foremost, and if there's a negative progression, such as a visual field loss or decreased visual acuity, then it can be optical coherence tomography or eye imaging may be required, followed by further visualization. For the same applies to neurologists, examination, neurological deficit screening, and so on. If there is an issue, then visualization. It should be the screening condition is very actually diverse and varies from doctor to doctor. However, careful clinical monitoring with a thorough assessment of all possible complaints and patients, followed by determining the appropriate timing for visualization, is truly important. But now I will move directly to tumors, tumors of the peripheral nerves. In fact, in neurofibromatosis type 1, there are 4 types in total. Cutaneous neurofibroma is a well-known condition. More than 95% of our patients have them. They are completely harmless, never undergo malignant transformation, can be removed by any convenient method, and are subject to repeated surgical intervention. And for the patients, this only cause a cosmetic defect, sometimes skin itching, but this is a minor issue. For them, it's more of psychological and cosmetic concern rather than a condition that poses any threat to life. And plexiform neurofibroma is a benign tumor by its nature. However, due to its ability to grow rather rapidly, or more precisely, not rapidly, but quite persistently throughout life, they continue to grow constantly. Yes, they can reach large sizes, leading to cosmetic defects, functional impairments depending on their location, and severe pain syndrome, because we are talking about the peripheral nerve. But there are also 2 types of such malignant tumors: a typical malignant peripheral nerve sheath tumor, which is purely oncological pathology. It undoubtedly requires aggressive intervention and unfortunately has an extremely poor prognosis. I want to point out that the plexiform neurofibromas unfortunately have a tendency to undergo malignant transformation, and over a lifetime they can develop into a malignant peripheral nerve tumor. Therefore, it's important to keep this in mind, be aware of it, and actively monitor these lesions. However, as I mentioned, a plexiform neurofibroma is a benign tumor, but it has extremely high vascularization and can reach large sizes with complex shapes, which in some cases makes radical removal impossible. At the same time, the severity of associated complications can be quite serious and present with a wide range of clinical manifestations. Here they are presented on the slide. First and foremost, these include chronic pain syndrome, functional impairment, and bleeding, bone destruction. And several other complications. In terms of classification, we can divide them into progressive and non-progressive based on growth characteristics, as well as nodulator of diffuse depending on the pattern of spread. And in terms of localization, there are deep ones which are most likely to visualize them performing magnetic resonance imaging or other imaging methods, and superficial ones which we can see with the naked eye. Here is a clinical case: a 5-year-old girl diagnosed with type 1 neurofibromatosis with a hereditary form. The diagnosis was confirmed using a molecular genetic method. You can see that from an early age she has a progressively growing plexiform neurofibroma at the right side of her neck, extending to her head. There was an attempt of surgical intervention due to the diffuse nature of the tumor growth and its localization. As you can see, the surgical intervention was not radical, and within a short period the tumor progressed. Naturally, such a patient is a candidate for conservative treatment with targeted therapy, which I'll be discussing today. I want to point out that biopsies are absolutely not recommended for confirming the diagnosis of plexiform neurofibromas. This is a frequently asked question. We can establish this diagnosis based solely on clinical manifestations and imaging in a patient with confirmed diagnosis of neurofibromatosis type. In some cases, a biopsy is dangerous and may result in bleeding, damages surrounding tissues, and sometimes an insufficient amount of material can make the procedure uninformative. Therefore, in most patients, the diagnosis is actually established based on clinical presentation and imaging. In cases where we suspect malignancy, have doubts about the diagnosis, or suspect malignant transformation, a biopsy is certainly indicated. And in all of these cases listed, you must make the decision using additional imaging methods, including, for example, PET-CT with fluoridated glucose. However, to confirm or rule out your doubts, you must certainly use a biopsy. As for the management strategy for patients with plexiform neurofibroma, in the past and even now, in fact, surgical treatment is the primary option. It's possible to remove this tumor, then it should be done. And the only problem may be due to its large size, risks and complications. Then it eliminates the choice method it ruled out. It is possible to wait and observe, and indeed a number of plexiform neurofibromas, if they are asymptomatic, if they don't cause any significant deterioration in the patient's quality of life, and if they do not behave aggressively, then such a patient can be monitored, and the treatment strategy can be determined depending on how the plexiform neurofibroma behaves in the future. And for the number of patients, there is indeed a certain percentage for whom we don't intervene, with only monitor, and they don't progress and live quite with a good quality of life, never requiring our therapy. And of course, drug therapy. Until today, we didn't have the possibility of pathogenetic therapy, whereas chemotherapy methods were tried, but all of them proved ineffective, and only the introduction to the market, the MEK inhibitor selumetinib, which was registered in Russia in 2021, allow us to speak of pathogenetic treatment. Thank you for your attention. I apologize for taking it a bit longer. Thank you once again, and thank you again. And it was Denikina Yulia Valerievna. Thank you very much. And we have the follow topic, applying anti therapy, and the speaker is Pulatova Nargiza Sirajidinovna, the main hematologist of Tashkent city, and she is also the head of the Department of Hematology from Uzbekistan. Use of antifungal therapy in oncohematological patients. Please keep the deadlines. Dear friends, thank you very much for giving me time. And my topic is, as already were mentioned, yes, please, technical group, if you can put the right presentation, we would be very glad. And please, if you can speak more close to the mic, because we cannot hear you very well. The acute leukemia, tumor clonal disease of the hematopoietic systems with primary damage, bone marrow, and subsequent damage to the internal organ. The substrate of oil is the blood cells. And when we have the acute leukemia, we have the tumor clone catabolism cells. It's hyperplastic syndrome, and it's also the operation normal sprouts of hematopoiesis, and it is going to uric acid, other extramedullary fossa neuroleukemia, cutaneous leukemias, and hemorrhagic syndrome, and it also goes with anemia and infections. The clinical manifestations you can see on this slide. You can see patients from our clinical experience. Thank you very much to my teacher and my Mr. Desurovich for giving this photo from his personal archive. We can see here it's a 12 years old girl, has acute myeloid leukemia with signs of maturation. The next, it's acute myeloid leukemia in infiltration of the tongue. Yes, it's acute myeloid leukemia. Yes, and you can also see on the slide we also have the hemorrhoidal syndrome. It's in the lymphoadenopathy. Very often we see this clinical it's a acute myelomonocytic leukemia, leukemic infection of gums. We can also see here the spinal lesion, infratumor of brain tumor, and we have the cut. We also can see here the cutaneous leukemias in patients with OMA, and our patients they usually have this. And the principles of treatment of acute leukemia.
For about 2.5 years, we conduct antimicrobial therapy, antibiotics, antiviral medications, and antifungal therapy as well. There is as well as additional therapy for erythrocyte mass, as well as thrombocytes mass, as well as the plasma. The algorithm of the stepwise diagnostics is conducting the antibacterial therapies to use the medicines of amikacin, amphotericin B. If there is no effect for about 24 hours, we need to conduct additional scheme of combination antifungal therapy for the next combination. Epidemiology and the risk factors. The main infections, invasive infections in oncohematological patients are considered to be the fungi, candida, as well as the aspergillosis types. And it includes erythropenia. We are conducting the intensive chemotherapy, transplantation of the hematopoietic stem cells, using corticosteroids. If we use all of these components, as well as the central and non-central venous catheters, then it will cause the development of the fungi, and of course the actuality of the antimycotic therapy, the usage of the new medical technologies such as invasive technologies, non-invasive technologies, and cytostatic immunosuppressive therapy, as well as the other ones, it will lead to the development of the mycosis. The insufficient knowledge of invasive mycosis, the complexity and labor intensity of diagnostics and inadequacy, and as a result, ineffectiveness of the therapy cause high mortality up to 70 to 100%. In this regard, the search of new approaches to control mycotic complications in immunocompromised patients, increasing the effectiveness of their treatment and prevention, seems very relevant. Main opportunistic mycosis in immunocompromised patients. Aspergillosis is quite common fungi caused by mold fungi of the genus Aspergillus, which affects, most often it affects the lungs in people with immunodeficiencies, with septic cause of the disease. Cryptococcus is caused by yeast-like fungi, Cryptococcus neoformans, characterized by damage of the central nervous system, lungs, skin, and mucous membranes, refers to AIDS-marked diseases. Invasive candidiasis is caused by yeast-like fungi of the genus Candida. Isolation of the pathogen from blood samples indicates candidemia. Its detection in any internal organs talks about the invasive type of candidiasis. Of course, when we talk about the invasive aspergillosis, this is the risk factor. Within the detection of galactomannan in biological analysis, serum, CSF, and etc. Detection of aspergillus supplement by microscope or respiratory substance by any histological examination of material from the lesions. On this slide, you can see the MSCT, the lung affected by fungi. Here you can see the palatos, the diagnostic criteria for cryptococcosis. In microscopy, detection of cryptococcosis by microscopy or culture of CSF, or determination of neoformous antigen in the CSF. And pneumonia, It is revealed by CT or radiographic signs of pulmonary mycosis, detection of these microbes, these fungi during mycological examination, sputum, biochemical analysis of blood, as well as biopsy from the lesion. Determination of neoformous antigen in the blood is also conducted in order to diagnose these fungi. Criteria for diagnosis of candidiasis: invasive candidiasis, candidemia, single isolation of candida supplement during blood culture, acute dissemination candidiasis, candidemia, identification candida supplement in the examination or the cultural material from the tissues. This is how candidosis looks like. This is effect of the soft tissue. Here you can see the tongue. Acute myeloblastic leukosis, disinfection of the oral cavity. Epidemiology of the form, usage of the antimycotic, clinical resistance is the ability of the fungi to survive and reproduce under the influence of therapeutic doses of antifungal drugs, which in vivo is expressed in the ineffectiveness of antifungal therapy. The classification of antifungal medications. Polyen, nystatin includes levocarnitin, levarin, lactamine, amphotericin B, azoles for the systemic usage. The first, fluconazole, iconazole, and etc. The second generation, voriconazole, ravoconazole, poconazole, albuconazole for the local usage, cotrimazole, miconazole, bifenazole, isoconazole, oxyconazole. The treatment of invasive mycosis in patients with hemoblastosis, the main treatment measures is the antifungal therapy, correction of the IC intracranial pressure, as well as reduction and coping with of the risk factors. The choice of medicine is amphotericin B, not less than 2 weeks after this voriconazole, 400 milligram per day, twice a day, not less than 8 weeks. There is the risk of development of nephrotoxicity. Instead, amphotericin B, it's used amphotericin B 5 milligram per kilogram per day, not less than 2 weeks. After this, fluconazole 800 milligram per day, not less than 8 weeks. And the continuation of the usage of antimicrobial, antimycotic effect, of course, it will be based on the condition of the patient, as well as the localization of the processes and pathology, as well as pharmacokinetics and the pharmacodynamic of the processes. Caspofungin, this is antifungal medication, which is within the group of echinocandides. It's used in order to treat invasive infections and fungi, which is led by Candida and Aspergillus. In comparison to other antifungal medications such as azoles, amphotericin B, caspofungin has certain differences, different in points. The mechanism of effect they will inhibit the effectivity of the cell membrane, and it's very effective towards certain beta-glucan type of fungi. It will affect negatively the structure and function of the fungi. Amphotericin, it is connected with ergosterol within the cell membrane, and which will cause the pores to be created, and it will lead to the death of the cell. What is the advantages and disadvantages? Caspofungin, advantages: effective against fungi that may be resistant to other drugs, such as azoles, low risk of toxicity compared to amphotericin B, doesn't have significant drug interaction typical for azoles, the usage in resistance. No. It is not used for the different type of infections. Caspofungin is used for the invasive infections, which is caused by candida, so for example, candemia, and aspergillus with the low immune system. Azoles can be used to treat both superficial and invasive fungal infections. Fluconazole is one of the most commonly used drugs for the treatment of candidiasis and cryptococcosis. Amphotericin B is often prescribed to treat severe invasive fungal infections such as mucormycosis, or in cases where other drugs are ineffective. Conclusion: caspofungin and caspofungin is an important tool in the treatment of invasive fungal infections, especially in immunocompromised patients. Unlike azoles and polyenns, its mechanism of action is directed at the fungal cell wall, making it useful in some causes of resistance. However, its use is limited to certain indications and requires intravenous administration, which makes it less convenient to use compared to other drugs available in oral form. Treatment. The choice of antifungal drug is determined by the type of the pathogen, localization of the infection, the patient's condition, and the presence of concomitant diseases. Recommended treatment regimes include invasive candidiasis echinocandins as a first-line therapy, lipid forms of amphotericin, the alternative variant, fluconazole is if the patient is stable and there is no resistance. Invasive aspergillosis, voriconazole is the drug of choice. Lipid forms of amphotericin B in severe forms of resistance. The prevention, based on the international recommendations, the prophylactic use of antifungal medication has certain risks of the risk of developing of antifungal medications. The choice of drug depends on the suspected pathogen, safety profile, and drug interactions. The most commonly used are fluconazole for the prevention of candidiasis, voriconazole or posaconazole for the prevention of aspergillosis. Monitoring correction of the therapy. During the process of the treatment, of course, we need to regularly assess the necessity and evaluate the effectiveness and tolerability of the therapy. Monitoring blood drug levels of voriconazole and poconazole, assessment of the liver and kidney function, dosage adjustment if it's needed. This is the type of caspofungin, the 50 milligram dose. Thank you so much for your attention. Thank you so much. We don't have time for questions, and we are out of the time frames actually. And as far as I know, our session is finalized now. It's a coffee break time. Thank you so much. Thank you for your attention. And of course, we want to thank our moderators for moderating this session. And after 20 minutes, there would be the next speaker here at 12:20 exactly.
Всех занять свои места.
Dear participants of the conference, please be
And of course, many people, they are interested in practical. That means that practical materials that we can use in our daily practice. And within this session, we will face those kind of practices. And now, in the next session, I will introduce you the coordinator of the next session, and Iskandarov Kavmodzinejinovic, he will be a moderator here, and also the guest. He will also be here with us. He was not a moderator, but although he will share his opinions with us, he is our guest from Turkey. He is famous doctor from the famous hospital in Turkey, and hoş geldiniz. Oh, welcome speech. And now the next speaker, Professor Ali Bülent. He's the director of the Department of the Bone Marrow Transplantation in Pediatric Department in Acıbadem Clinic, which is located in Vodanam.
Sevgili oturum başkanım, değerli bu güzel kongrenin değerli dinleyicileri, sevgili aziz karındaşlarım, dostlarım.
Dear friends, dear guests, dear partners, I'm coming from Turkey, and I will speak in English. Sometimes it will be translated. I will speak in Turkish as well, and I have an interpreter here. Good day, everyone. I'm very happy to meet you all here. Within the conference, this time today I will speak in English. Next time I will try to speak in Uzbek language. I have 15 minutes. And in 15 minutes, and today I will talk about the pediatric haploidentical hematopoietic stem cell transplantation.
Gapla identik bolalardagi ilik ko'chirish amaliyoti haqida.
Tekrar İngilizce slide.
The slides are in English language, and I will try to speak in English to explain to you.
Sizlardan uzr so'rayman.
Şimdi İngilizceye başlıyorum. Çeviri yapılacak teknik ekip tarafından.
Texnik xodim
Due to the technical. There is a English translation, and I will start speaking English.
My colleagues, I start with agenda, and here you can see the history and development of haplotransplantation Firstly, I talk about, and then principles of haploidentical transplant, role of post-transplant cyclophosphamide treatment, and then role of alpha-beta T cells depleted and CD19 cell depleted transplants, and the last topic for me to understand and manage complications of haplo-BMT. And the last slide is about our countries and our centers' results. All hematologists, I think that, know very well this man. This is the father of the bone marrow transplantation. The name is Donald Thomas. He earned a Nobel Prize in 1990 for establishing bone marrow transplantation as a successful treatment for leukemia and other blood conditions. I'm lucky to meet him, and maybe you know that he died October 2012. Firstly, I would talk about the diseases that we transplant in all children. I mean that the indication of bone marrow transplantation. As you can see in the slide, autologous transplantations indications include to relapsed Hodgkin's diseases, relapsed non-Hodgkin's lymphoma, stage 4 neuroblastomas, and relapsed Ewing sarcoma, and rarely we perform the metastatic Ewing sarcoma, medulloblastoma, and other brain tumors and autoimmune diseases. But as you know, mostly in pediatric settings, we perform the allogeneic transplantation in all children, and mostly the diseases include the malignant diseases, and mostly leukemias depend on the using the protocols like a BFM AML 2009 or the others, or BFM ALL, or relapsed BFM ALL protocols. Indication will be changed, but mostly I can say that AML CR1 if patient high risk group, or ALL CR1 if patient high risk group, like a Philadelphia positive ALL or Philadelphia like ALL or high risk group of the other ALL group as an indication for bone marrow transplantation in pediatric settings. The others, relapsed or refractory AML and ALL, chronic myelogenous leukemia for only tyrosine kinase inhibitor refractory or after-blastic crisis, juvenile myelomonocytic leukemia, myelodysplastic syndromes, and primary or secondary hemophagocytic lymphohistiocytosis. Let's see the other non-malignant diseases. Mostly you know that the inherited metabolic disorders like adenoleukodystrophy, Hurler syndrome, metachromatic leukodystrophy, osteopetrosis, and others. And it's very important that in pediatric settings, the diagnosis of inherited immune disorders, all severe combined immunodeficiency syndrome, Wiskott-Aldrich syndrome, and others. As you know, the other inherited red cell disorders like a poor red cell aplasia, sickle cell diseases, and mostly you see in Uzbekistan beta thalassemia major and others, and bone marrow failure states like a severe aplastic anemia, secondary severe aplastic anemia, Fanconi anemia, and the other congenital bone marrow failure syndromes. Here you can see in this slide EBMT activity of 2019. Maybe you know that 70 teams in registry in this EBMT group from the 50 countries, and approximately 50,000 transplants performed per year. In pediatric settings, as you can see in this slide, mostly indications for leukemia group, AML, ALL, and I can show you ALL, and hemoglobinopathies, and primary immunodeficiency patients group. It's very high in the pediatric settings as an indication. In this diagram, also you can see it every year, step by step. In red line, autologous transplant, The blue one is allogeneic stem cell transplant, increasing per year in step by step. This is a hematopoietic stem cell activity between the 19 and 2019, the first stem cell transplant activity. As you can see here, haploidentical transplantation, my topic is, as you know, as a pediatric haplotransplant patients, haploidentical transplants, after the 2010, every year, step by step, increasing the number of haploidentical transplant, increasing very fast. As you can see here, haplotransplantation types in children depend on the conditioning, change the two types of transplant. Many pediatric hematologists and oncologists know this. If some centers use post-transplant cyclophosphamide setting, and some centers choose using the alpha beta T cells and CD19 cells depleted transplants. You can see here the timeline of the major GVHD prophylaxis strategies for high-risk patients undergoing allogeneic hematopoietic stem cell transplants. The red one is the cyclophosphamide with the post-transplant cyclophosphamide. As I can said before, in 2010 and then the 2012 post-transplant cyclophosphamide in haploidentical transplant is started and then developed to 2020. And as you can see in here, as a green one, ex vivo graft manipulation. As you can see here, ex vivo CD34 selection is started and developed in 2020 and started with the alpha beta T cell depleted or CD19 depleted graft and graft engineering in this haploidentical transplantation settings. Here you can see comparing the approach to mismatch haploidentic transplant after the post-transplant cyclophosphamide, advantage and disadvantage. You can see in the left side of the slide, T cell depleted, alpha beta depleted transplant. If you perform this transplant type, you can see the better overall survival, less acute GVHD, and faster engraftment for patients. But we have to know that in the settings, primary graft failure will maybe increase, and second transplant will be needed. Adenoviremia infection is very frequent in this transplant type. As you know, that the expensive type of haplo and very complicated cell processing needed. If you use the post-transplant cyclophosphamide for haploidentical transplant, you know that the low cost and widely available, no specific cell manipulation, and sometimes you can see at the end of the transplant procedure, primary graft failure. Some patients need second hematopoietic stem cell transplant. If you compare the other type, sometimes you can see the worse overall survival and increased organ toxicity and more acute GVHD, and we know that occur slower engraftment. As I said before, in 2001, the Baltimore Group first clinical study with using the post-transplant cyclophosphamide and was able to protect patients from the GVHD after haplo transplants. This haplotype, not only GVHD could be prevented, also, but graft versus leukemia effect superior, at least in this study with Hodgkin lymphoma. Here you can see some studies about the haplo transplants. A total of the 30 studies, including, this is a review, approximately 23,000 participants in the study. Post-transplant cyclophosphamide increased all-cause mortality compared with the match-related donors. Similar with MAT transplants, I mean that the matched unrelated donors, and reduced with the mismatched unrelated donors. Non-relapse, when you can see the non-relapse mortality, worse outcomes compared with the match-related donors, but better outcomes compared with the MAT transplants, match-unrelated donors. What about the relapse? If you use the post-transplant cyclophosphamide, was a similar outcome compared with the match-related or mismatch unrelated donors. But we know that showed increased relapse compared with the MATs. When decided to perform the bone marrow transplant as a haploidentical, our source sometimes bone marrow or sometimes peripheral blood. Now 2 studies comparing the bone marrow versus peripheral stem cell for unmanipulated haplo transplant. One of them, the EBMT study, showed that the increased GVHD 224 and 324 with peripheral blood, same chronic GVHD, same relapse, and same 2-year overall survival, 55% and 56%. When you look at the CIBMTR study, increased GVHD 2 and 224, but not 324 with peripheral grafts, increased chronic GVHD and reduced relapse. Survival at 2 years also in this study is quite similar, 54 versus 57%. Here you can see the advantages and limitations of haploidentical donors. Our major advantage, increased availability of highly motivated donors. When you're looking for the donors, you can use the all donors and all family. Immediate availability is very important. Also, adequate doses of hematopoietic stem cells. It's very easy to use for patients. Lower cost of graft acquisition. Immediate availability of the donor for repeated donations for hematopoietic stem cells or lymphocytes to treat relapse. Here you can see the major disadvantages with using the post-transplant cyclophosphamide. Higher rate of fatal graft rejection, severe or fatal GVHD in the absence of effective prophylactic measures, increased non-relapse mortality due to infectious complications when you perform the post-transplant cyclophosphamide in the haploidentical transplantation. As I said before, you can see all families or siblings, children, aunt, grandparents, cousins will be maybe donor for patients. Choice of the best haploidentical donor, how we can do? We need the general criteria. First of all, it's very important donor recipient, human cytomegalovirus serology, donor age, donor sex, donor recipient body weight. But if patient have malignancies like a leukemia, the other important options it's need the planning for the other options of the criteria. Only in malignancies, like a larger size of NK alloreactivity subset, like a KIR haplotype, like a higher B content value in B haplotype donors, like a presence of the educated KIR2 DS1 in case of C2 patients. Here you can see the protocol. The first protocol, it is named the Baltimore protocols, but we can't use at the moment. The other modified post-transplant cyclophosphamide regimen, as you can see here, we performed our patients this protocol. It's very easy to use this protocol. As you can see here, it's very important that the 3rd and 5th day performing the cyclophosphamide as a post-transplant days, and after this is a GVHD prevention protocols, and very easy to perform for patients. If you perform the post-transplant cyclophosphamide in haplotransplant settings, we have to know that, as you can see in the upside, you can see the progression-free survival. It's about 50%. Overall survival, it's about 40%. And non-relapse mortality and relapse, it's about 30%. This is very crowded slide, but I can't talk about this slide. But we know that it's very important in pediatric patients because the first pediatric study in the haploidentical transplantation using the post-transplant cyclophosphamide. In this study showed that the first multi-center trial of myeloablative conditioning haplo-BMT with post-transplant cyclophosphamide in pediatric patients with acute leukemias showed 0% transplant-related mortality and 0% grade 3 or 4 acute GVHD. It's very important for using the pediatric haplotransplants because mostly we lost the patients because of the acute GVHD, the severe acute GVHD. This study showed not only this very important knowledge, show us the moderate to severe chronic GVHD and similar relapse rates as those of matched donor BMT. Here you can see the protocol of this study. As you can see here, if you use the only chemotherapy settings for conditioning, busulfan, cyclophosphamide, and post-transplant cyclophosphamide after the infusion of the T-cell depleted bone marrow, and for graft versus prevention, mycophenolate mofetil, as you know that as CellCept, we use the 50 milligram per kg, sometimes for peroral or intravenously, but most important things to use the third and 5th day, the cyclophosphamide, 50 milligram per kilogram per day for prevention of the GVHD if you perform the bone marrow transplant. Sometimes we can choose the TBI-based preparative regimen, conditioning regimen. In this setting, also we use the cyclophosphamide, TBI, then bone marrow infusion, and also it is the same dose and it is the same strategy for prevention of the GVHD. And also, we don't forget the cyclophosphamide as a post-transplant 50 milligram per kilogram per day. Here you can see the alpha-beta T-cell depleted, how it works if you use the alpha-beta T-cell depleted haplotransplant settings. As you know that we, in this protocol, hematopoietic stem cell enriched the cell populations are obtained by negative selection upon removal of the T-cell receptor alpha-beta T-cells and also CD19 B-cells altogether. And notably, in addition to CD34 cells, these cells suspension contain mature NK cells in here, T gamma delta cells in here, and also stem cells, CD34 stem cells. 2 weeks later, change the NK cells. After 4 and 6 weeks, alloreactive change the NK cells and prevent the no graft rejection in the patients, targeted the patient's T cells, and also affect the dendritic cells and prevent the GVHD. Other NK cells and T cell, gamma delta T cells, control all the infections a few hours later and killing the leukemic cells and preventing leukemic relapses. It works like this as a diagram. In this study, it's very important for pediatric, show us TCR alpha beta and CD19 cell depleted haplotransplant is characterized by low non-relate mortality. It's very important. Low non-relate mortality and acute and chronic GVHD also it's very low percent, and with overall survival and disease-free survival similar to other transplants type. I mean, if you perform the MAT, match unrelated donor, or if you perform the mismatch unrelated donor, if you perform the full match transplants, it is the similar overall survival or disease-free survival. If you use of the TBI in the conditioning regimen, transplant in CR1 and 2, and low negative levels of MRD, it's very important. If you send some patients for haploidentical transplants to our center or to our country, we plan that, and we must learn that patient in CR1 or CR2, and we have to know that what is the MRD percent, what is the MRD positive or negative, because affected transplant conclusion or transplant outcome. If negative MRD improve the outcome of the haploidentical transplantation. You can see this study show us the TCR alpha beta and CD19 depleted HLA haploidentical transplant is an effective not only for leukemia. This is severe non-malignant disorders also is very good outcome. If patients given this type of transplant benefit from a low incidence of GVHD and transplant-related mortality, with graft failure being the main obstacle, unfortunately. You can see this acute GVHD rate, it's about 20%, and also the severe GVHD rate, it's about only 15%. It's very low rate if you use the alpha beta T cell depleted transplant. But we have some problem about if we perform the alpha beta T cell depleted transplant, because when we look at the patient's immune constitution, I mean that the patients after transplant, the lymphocyte count, you can see over there in the upside, the 18 months need the immune reconstitution for CD3. I mean the T cells. Also for B cells need 18 months. If patients return to Uzbekistan, return to Tashkent, we have to know that the immune reconstitution needs 1.5 years at least for when compared to normal population children. So it's very important because we have to wait the immunization for this patient's group. Let's see the haplo, as I said before, started with the megadoses of hematopoietic stem cells. Also now we use the post-transplant cytoxan, and also we use that TCR alpha beta and CD19 cell depletion. Also we use the MRD-based T cell titration, but the others as an experimental only. But when we talk about this, wait to us the ex vivo CLP and pro T cell expansion, T cell at backs with safety switch, and recipient tolerized donor T cell. And as you know that in the pediatric settings, some countries now perform the donor CAR T for graft or for patients. This is the important points of the haplotransplantation. You can see here the pioneering work of the Perugia group. HeLa haplotype mismatch family transplants show us the rapidly increasing in numbers with encouraging results in most centers, also in Turkey, and true with different stem cell sources like a peripheral blood, like a bone marrow, and different conditioning regimens and different GVHD prophylaxis. Only in one word, there is more than one way to perform haplotransplantation in pediatric settings. This is our transplant numbers. I am head of the bone marrow transplant centers of Turkey in 2022. And in our countries, here you can see the number of the transplants in per year. Please look at the last one from the 2022. As you can see here in Turkey, every year, all transplant centers perform, it's about approximately 1,000 or 1,100 transplants, mostly in the blue one, mostly allogeneic transplants, total number of blue one, and the orange color is the allo transplants. In pediatric settings, 90% of transplants include the allogeneic transplants, as you can see here. And recent years, last 5 years, it's approximately 1,000 transplants performed in Turkey in all pediatric transplant centers. When compared the transplant types, like a EBMT, in Turkey also haplotransplantation as an orange line increased step by step in every year, started with 2010 and now up to 100 transplants as a haploidentical in all transplant centers in Turkey. This is our center's results. As you can, we calculated only 2009 to 2022. As you can see here, look at the haploidentical type. It's about 90% for 100 days, and for 3 years, this is free survival. It's about 80, 85, except the 2020, because as you remember that some problems in the infection in all around the world, like a pandemic. Haploidentical is very complicated. This is our Uzbek patient, very crowded slides and very crowded protocol. Every patient is different. Every patient needs different transplant type. If patient have kidney problem, need personalize the transplantation protocol. If patient have a cardiologic problem, also need some prevention of the protocol. Depend on the patients, we decide the protocol and we decide to change the protocol, but the basis schedule is very similar in all the patients. This is the other leukemia patients. We performed the haploidentic alpha-beta T-cell depleted transplantation from the patients from the Uzbekistan. And now he is the 7th day after post-transplantation. Also very crowded, also very complicated protocol we use. This is our service unit, you can see. And this is our transplantation unit. We have 5 plus 3 beds, overall the 8 patients for only post-transplant settings. Here is the apheresis unit. Here is the flow cytometry laboratory, our outpatient clinic, and our the old team, you can see. And I would like to thank all my teams and all my personnel, all my doctors, nurses, and the lab technicians for this good results. Thank you so much for our speech.
It was a great performance. Thank you so much. Gerçekten çok iyiydiniz. Çok teşekkürler. Ve böyle bir prestij yerde tekrar görüşmek nasip olsun.
Thank you very much for this interesting presentation, and welcome to Uzbekistan. Thank you very much for your expertise and for your very precious knowledge. Dear friends,
Neuroscience in the hematological diseases of children, young adult. Keep in touch with us, Professor Chitalkal Prakash, Director Sri Aurobindo Cancer Center. Please, Mr. Prakash.
Share the screen. Yeah. Damia Gospoda, Vinaya Jabut, Dr. Colonel Prakash Chitalkar, Professor of Chemotherapy and Medical Oncology at Aurobindo Institute in Medical Sciences in Indore, India. This is the land of Raj Kapoor and Mithun Chakrabarti. I'm thankful to the organizers for giving me the opportunity to speak at this prestigious international meeting, bringing together medical oncologists and pediatric oncologists and transplant physicians from so many countries all over Europe and Asia, parts of. So it's actually amazing, and thank you so much, organizers. There are global demographics of will include children and young adults as a kind of unitary entity. Almost 8 billion of us are living on this planet. More than 4 billion of us are young adults. 160,000 children with new cancers are diagnosed globally every year. Even adolescent and young cancers account for about over 6% of all cancers. That means about 1.3 million out of the total of 19 million uh, every year occurring in the world. Both the children and young adults with cancer now achieve about 85% survival in the developed world. But many parts of the developing world, like India and even Uzbekistan and parts of Central Asia, I'm sure the outcomes of children and young adult cancer are not so impressive. Well, in our country, we are an aspirational society. Sharing is our civilizational value, and optimal use of resources just comes pretty naturally to us as a value. The youth bulge of India in the age group of 15 to 29, almost 54% of all the population in our country falls in this age group. And the estimated about 6% or 8% of the cancer burden in India is also among the teenage and young adult cancers. About 178,000 new young cancers are diagnosed in the year 2025. The age bracket of 15 to 30 years, based on a government definition of youth, and a new young person per day, every day diagnosed with cancer, about 480. So this is probably an underestimate, as about 40% of them are diagnoses which are missed. And what happens in Midwest India, like where I come from, the median follow-up of 21 months out of 400 cancers in young adults, almost 200 are still alive. And a median follow-up runs to about 6 years. And many of them have gone back to their jobs. Some have got married. Some have even born children. But a sizable percentage, about 40% of them have actually died of their cancers. And just a small percentage, about 23 out of 400, that is 5%, are actually lost to follow. So we are getting there. We are improving our follow-ups. We are improving our application. And what is it that makes us do? Well, in 10 years' time in my institution, out of 13,000 new cancers incident registered, about 6%, that is 780, were belonging to this age group of young adult cancers. And addressing them has been a challenge, but we have done bridging financing, providing hostels, providing counseling, including fertility, advocacy support, and youth volunteers. And so we are able to now track patients who may get lost to follow. The cancers, majority are, of course, leukemia, lymphoma, brain cancers, testis cancer, breast, colon, and thyroid. Adolescent and young adult cancer care pathway development is an ongoing process right now in our country, and a small percentage of our cancer centers in the large cities like Mumbai and in Chennai and in my own center Indore and in the city of Jaipur, there are weekly AYA outpatient clinics. Twice a week, there is AYA outpatient clinics in our center, and specialist AYA focus, which is multidisciplinary, which is involving the psychology, involves fertility care, and also involves intensive age appropriate care so that they get care which is appropriate to their age. And we are trying to create a transition system between children and young adults also. In the southern city of Chennai, there's district-based registry of the AYA cancers, which I'll come back to a little later. And in the northwestern city of Jaipur, they actually have a AYA cancer ward. So how have we got here? What is the organizational structure? Well, we have a national non-profit called Teenage and Young Adult Cancer Foundation called TICAN, and this is dedicated to the mission of every young person with cancer, which must get a chance for cure and to live life's dream to the fullest. It is registered as a non-profit company in 2016, and it is integral with an alliance of professionals, which also includes young patients who are survivors, caregivers, volunteers. They are all integral to our effort. And we have two target populations: young persons with cancer and also survivors of childhood cancer, which both have similar problems. How to get there? Well, awareness in schools, school books, application design, digitization, online consultations, access to care. Once a young person is diagnosed with cancer, he must get access to the nearest cancer center which is well equipped. And now we have a national program of unrestricted healthcare facility to every young person with cancer called the Ayushman Bharat. Then age appropriate care. It means young persons must get care appropriate to their age. So there is a process of assent consent, which will be involve the young person with their, according to their age, they are asked questions, they are provided information about their cancer, and we get surprisingly candid answers about the issues of survival, issues of diagnosis, issues of expectations from treatment, and issues of outcomes. So autonomy redefined. It means the young person must be given the opportunity to give the best. He must get the opportunity to take a decision about his treatment, and which is over and above, is exclusive from what the parental control might require. And advocacy with all the stakeholders in the care of a young person, which includes educators, which includes the employers, which sometimes often includes the government agencies, because advocacy is key to actually get them their due. The vision is reaching every young person with cancer by 2027 by means of registry, by means of avoiding abandonment, by means of care pathways, and also creating a service for care pathways and support either in hospitals and or in society. Well, India and Uzbekistan, as you see in this map, are two different countries, but in the same Eurasian landmass. And I understand Uzbekistan, they see as many as 3,500 new cancer patients per year. And well, we have got a massive population and as many as 178,000 new cancers in the young adults every single year. So there's plenty of scope for collaboration, and we are open to that. And how to do that in a transnational perspective? Well, leveraging India's centuries-old cultural ties with Central Asia, including Uzbekistan, leveraging our multilingual and diverse societal values with easy access to care now, with both societal values and with the government support, culture appropriate care for children and young adults, which is common to both countries, and I'm sure we can do that if we collaborate, and creating a training competence delivery model by communicating with each other's strengths and weaknesses. And we have a organization called INPOC, Indian National Pediatric Hematology Group, clinical trials recruiting increasing number of PAYs, children and young adults. So that is happening, and I'll show that in the next slides. Engaging with the local healthcare system to create solutions which will be culture appropriate. The national training program in pediatric oncology has been running in our country since August of 96. That means nearly 30 years now. And the target audience is always a group of local pediatricians and trainees to sensitize them for early diagnosis of cancers in the young age group. Now we started including the AYAs in them. Stabilization, follow-up. Format is a 1 to 2 day workshop, lectures and workstations. Reading material is given almost 2 months in advance. I mean, slide sets. Trainers are usually pediatric oncologists and a central observer who's a senior faculty, a local organizer, a pediatric oncologist, and a pediatrician. The INPA now is the research organization which takes care of and actually ideates and implements studies in children and young adult cancer. This is the INPA group formation way back in September 2002. And this is how it has progressed. You can see the red dots across India expanding as study sites. and sites which actually involve them in themselves in the studies. So you can see the recruiting number of sites are increasing. The patient recruiting are now going up to 22,000 in 2025. Projected number of children recruited in the slides are almost 22,000. Participating centers are now 175. The INPOC member institutions are over 70. And now we are almost 18 to 30 publications as a result of this collaborative research. So now coming back to southern state of Tamil Nadu, you can see every district. It's a state of 76 million. So, and as of January 31, 2025, every district now we know the registry data. Now we can track every cancer patient, including the young adult cancer patients. And most common cancers are leukemia, lymphomas. And you can make out that the status of patients, well, almost 50% of them are alive, 60% of them are alive, and the abandonment has been reduced. And so this is the beginning. One single state in our country has been able to do remarkably well with the administrative units of districts, creating registries and following them religiously. And I think this is the model which you're going to follow in our country, and we can follow in several Eurasian countries if we decide to collaborate. So these are the publications from the INPOC group, reducing chemotherapy dose intensity by 25% and giving rituximab has improved survival in the pediatric mature B-cell non-Hodgkin's lymphoma in the LMIC setting, low and middle income countries, utility and impact of telemedicine in childhood cancer, mixed method study, and so on. This is just to give two examples of several publications. So we also have youth services coordinators and youth organizations which do programs with a central message of you are not alone. We are all there for you, and to actually to handhold the young person, childhood and young person in their journey of the cancer, and help them through the whole process of the journey of diagnosis, treatment, sometimes treatment failure, even relapses, a second line treatment, and final outcomes. To conclude, collaboration is key to the improvement in the outcomes of young adults throughout the developing world. Culture-specific care pathways can be treated in every country, ensuring access, age-appropriate care, and advocacy. And cancer survived is a life revived, and young people deserve better. And to end, I will say spasiba balsoe. Thank you very much for this opportunity. I'm open to questions. I'll be happy to answer either in the chat box or personally. Thank you so much.
Спасибо большое.
Thank you so much. And now, the next topic. Do you have any questions to Professor Prakash? Are there any questions to Professor Prakash? No? If we don't have questions, thank you so much. And in continuation, the floor is given to Iskandar Kamal Zainuddin, which he is the head of the Scientific Medical Center of Hematology of Uzbekistan. Good day, dear conference participants. I'm very happy to see you in Uzbekistan. Pediatric National Center starts from 2022. There is a department of hematology with 20 beds, and now we will talk about the bone marrow transplantation and the practices of using it in our settings. In general, as soon as our clinics launched and opened, we try to conduct this bone marrow transplantation works, and since then we built the isolation box. We tried to buy the equipment for that, and after that, in order to conduct this project, we worked in close collaboration with certain partners, and we should have to say that our leaders, Bakhtiar Ilgar Jumarov, they had a communication with Professor Loris Fartner from Italy, from Germany, Jan Joran Sorensen, and professor from St. Jude, Ali Suleiman, Gavra Haria from Apollo Hospital from India, as well as our professors of Akhur Ghafurov, as well as Deputy Director Sabir Fudikhangirziev. They gathered like a leading group, and in order to promote this activity, we had certain nurses. We had also coordinators, Saida Bigali, specialist, Pakir Sagirjan, Ankas surgeon Islam Musarwar, a young specialist Parpir Bigzod, a young specialist Abdul Ghaffar Fazamjan, clinical resident Sultan Sajodai. They were involved. And as I said, special nurses were such as Rizimova, Alimura, Narbaeva, Sakova, Amanova, they were all involved within this process of implementing this bone marrow transplantation. This is the part of our lecture, the structure. And the next one, the importance of the bone marrow transplantation, the sponsors, the equipment, specialists in transplantology, conducting the allogenic and autologic transplantation results, and etc. Our department That's what we have 4 doctors within our department. We have 15 nurses working, and all type of investigations are conducted here. As you can see here, the members of our departments are here. Now, I want to stop in the multidisciplinary approach because it's important to have multidisciplinary approach in order to provide this kind of bone marrow transplantation. That's why within our center, we have all the doctors such as nephrologists, genetics, endocrinologists, and etc. Now we have ICU unit, and we have all the investigations made in our center as well, such as PET scan, CT, and etc. Our laboratory should be very modern because all the blood tests, molecular and genetic tests should be conducted. It's also important to have a proper hemodialysis center because after you do this kind of so like probably there should be a need for hemodialysis if it's needed after the bone marrow transplantation. The relevance of the bone marrow transplantation every year, 400,000 children they have cancer per year, and in Uzbekistan close to 1,100 and 1,200 children they have certain hematological oncological diseases per year, and they in order to conduct the treatment there would be some like chemotherapy, radiotherapy, as well as bone marrow transplantation is an option for treatment, and it should be conducted in a proper price, not expensive, and we need to, the main idea is to save children's life, and it should be provided in a price which is feasible for the Central Asian countries. Our collaboration is conducted with the Ministry of Health of Uzbekistan, and our initial partners are the company DKMS. This is a non-governmental organization from Germany. They support people, children with the oncological and hematological diseases, and they provide the donors for more than 12 million list of people they have, and together with the Ministry of Health we work in close collaboration. We signed a contract and we start working on this from 2023. These representatives of DKMS, they came to the Ministry of Health, and within the premises of the Ministry of Health, we signed an agreement with them. And in addition to that, there is a partner in other children from Italy, the Professor Lawrence. He is the founder of this company, and we are working on the allogenic bone marrow transplantation. He supported us in this regard, and they have a lot of branches all over the world, and Uzbekistan is also we are also part of this, and we are working in close collaboration with those Italian guys and our nurses and now specialists. They They went to India, to Bangalore for about a month in order to be trained for conducting the bone marrow transplantation. And in addition to that, we have MOU with Apollo hospitals on autologous bone marrow transplantation. We conducted it together with Apollo Hospital. And regarding the allogenic type of bone transplantation, we are working it in collaboration with the BTMS organization, BKMS. Of course, the sponsorship in order to conduct the transportation, Minister of Health as well as the other sponsors, they support us. The first of all, Zamin Foundation, they provide us the equipment, and of course, Esgo Amal Foundation, they supported us a lot. They provided us 504 billion sum. They brought us equipment for transportation of block, the main instruments, as well as the medicines for doctors, as well as they covered the costs of the staying in the hospital for patients who are undergoing the bone marrow transplantation. And in addition to that, patients of certain patient parents, they also supported us in order to buy certain equipment such as Optia Spectra, apheresis, etc., apheresis, and the company itself, they also support us because they taught us, our staff, to train how to work on this equipment. And this block started to be built from 2022 to 2023. We planned to conduct the 3 bone marrow transplantation at that time. We plan to do simultaneously 3 bone marrow transplantation there, and experts from Turkey, Korea, etc. They came here and explained how we should have to conduct this bone marrow transplantation, we should build it. And after this, we start building this kind of departments. And in order to do the autologous and allo transplantation, we try to follow the EBMT handbook. We translated it into Uzbek language, and we are using certain protocols. And we approved it within the Center of Pediatric Hematology and Oncology, and we are using it. And we start doing the selection for the patients who is for allogenic bone marrow transplantation. At the beginning, we took the beta thalassemia disease first, and we discussed it with the DKMS experts, and we decided to choose the risk selected based on the risk group. We registered all the family members of the patient who is higher than before 8-year-old. We also took these patients outside, and at the beginning, the patients from Surkhandarya were selected, and we started doing the preparation for allogenic bone marrow transplantation for them. And experts from Germany, Professor Jan Sorensen, as well as from England, Suleiman Siddiqui, she came to us in order to support us for about 15 days in conducting the bone marrow transplantation in an allogenic way. We made with those specialists together this allogenic bone marrow transplantation. Here you can see the pictures. We placed it here. And within the pediatric center, we start doing this autologous bone marrow transplantation, which is done. This is the list of patients who went through the autologous bone marrow transplantation. We conducted up to 14 cases in our center, and this is the like some of the scheme of the how we will use the cell mobilization and harvesting of CD34 cells and the Optia spectrum equipment. And when we talk about the allogen bone marrow transplantation, we added 3 patients to this list, but now 1 more is preparing, and he doesn't need a blood transfusion yet. For the patients who has low risk for beta thalassemia, this is the diagram how to conduct this bone marrow transplantation, how to provide the medicines for these patients, how to use fluoradribine as well as busulfan and cyclophosphamide as well. And in this department, This is the information about the treated patients within our department, and our main aim is to treat as much as possible patients. And this year, we had 1,425 patients who were treated in our departments. In addition to that, but there are more because we have certain we also conduct a different unique type of surgeries for sarcoma, Ewing sarcoma, osteosarcoma, non-Hodgkin lymphomas. We are conducting the aspiration biopsy of the bone marrow. We also use low invasive methods to remove different head and neck tumors, and we also do the Whipple type of surgery. We also do the sclerotherapy of the big lymphomas, giant lymphomas, and we also remove certain big tumors in from difficult locations. And when we talk about the scientific capabilities, our specialists, they go to different foreign conferences, they publish in different important journals. We had nine publications from previous year results. Autologic, there are 14 patients who conducted autologous bone marrow transplantation. Now their condition is good and they are not under the bone transfusion. And we are conducting once a month checkups of these patients, and the results are very good. And at the end, as a conclusion, we can say that based on the possibility in developing countries, by using low amount of resources, we can provide autologous bone marrow transplantation, and that's why we should help the patients who are staying within the Republic of Uzbekistan without taking them outside of the country. And this is the new step in order to develop the centers of the transplantation in our country. And the future results, plans to implement the endoscopic embolization processes, as well as conducting the developing the enlarging the block of bone marrow transplantation, enlarging the amount of increasing the amount of patients who will conduct the bone marrow transplantation. We want to use the immunotherapy for other nosologists, and in addition to that, we want to provide a proper treatment for patients with thalassemia in the rural areas. Those are our plans. Thank you for your attention.
Thank you very much for your very interesting presentation. And so we are going to continue. And now we are having a professor from Turkey. And the topic is initial results of targeted therapy in children with relapsed Hodgkin's lymphoma.
Speaker Saitov Bigal.
Saitov Bigali Shokhir Ogle, please, the floor is yours.
Assalamu alaikum, hurmatli ustod.
Dear participants, welcome to our lecture. And the topic of my report is about children with Hodgkin's disease. Let us start that there is no conflict of interest and no funding from pharmaceutical companies to my side. So, Hodgkin lymphoma and treatment options for relapsed Hodgkin's lymphoma and the importance of target therapy in the treatment of Hodgkin's lymphoma and examples and results from the practice and summary. So if we talk about Hodgkin lymphoma disease, it is 5 to 6% of oncological diseases found in children. One of the oncological diseases in children with high indications for treatment, and it's possible to treat even in conditions of limited resources, and relapse of refractory forms of the disease are observed in up to 15% of patients. If we look from the biology side, about 90% of all Hodgkin's lymphomas are classic Hodgkin lymphomas. We also have mononuclear Hodgkin cells and multinucleated Reed-Sternberg cells, and although they originate from germinal central cells, classical Hodgkin lymphomas show fewer V cell markers. If we look at the WHO classification, then we can see that the histologic type, we have classic nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte-depleted, not nodular lymphocyte predominant. And we can see the morphologic appearance and the tumor cell immunophenotype. We can see that there are positive and negative sides of it. If we look the cellular classification, then we can see classic XL and predominant nodular lymphocytes, 5%. And relapsed refractory Hodgkin lymphoma disease treatment methods. We can see here traditional chemical treatment with the chemical treatment with BV and checkpoint inhibitors. And I would like to also see that here we also have some combinations, and of course we sometimes use not the same protocols for treating the patients. Then conventional chemotherapy, we use new treatments. Of course, if it's conventional, then the progression-free survival is 80 to 60%, and 5-year survival is 70 to 80%. High toxicity we have as a disadvantage, and relatively cheap and relatively more hospital days, so which is also disadvantage. And if we look at the new ways of treatment, then we can say that it's like higher complete before after transplantation metabolic response up to 83%, 2-year progression-free survival 63 to 81%, up to 81%. We see less toxicity and relatively expensive, which is not advantage, and it can also be taken in ambulatory conditions. So we can see from the slide that there are advantages and disadvantages with conventional chemotherapy vs new treatments. If we also have a look at a different kind of research, specifically now I am looking at clinical lymphoma and leukemia. It's Elsevier, and there are different kind of research around this topic. Then regarding the treatment itself, we use brentuximab vedotin plus bendamustine, a highly effective regimen in relapsed refractory Hodgkin's lymphoma, and patients received a BV 1.8 microgram per kg on day 1 and bendamustine 90 mg on days 1 and 2 every 21 days. And you can see also on the slide how we can organize it. Also, if we look that it's also can be response assessment on days 15 to 21, and then we can see if it's required, what is required, and then we have also combination and optional monotherapy, and of course it's all based on response assessment. Now you can see on the slide BV mechanism of action. I really like this scheme. I think it is very understandable, and it shows what we do with this. You can see here that we have anti-CD30 monoclonal antibody and monomethyl auristatin MMAE, microtubule disrupting agent, and we can see that it's go with the receptor-mediated endocytosis and endosome, and then MMAE is released by lysosomal proteases, and it binds it, and it leads to the death of the cells we don't need. Results materials and methods between 2021 and 2025 for patients with relapsed Hodgkin's lymphoma were treated at Children's National Medical Center. Two patients ranged in age from 3 years, 6 months to 11 years, 3 years. So it's all children. Two of the patients are boys and two are girls. The diagnosis was confirmed morphologically in all patients, and expression was determined by immunohistochemical method in all samples. Also, the ABPV was chosen as the first-line chemotherapy program. We had 6 courses, and it contains doxorubicin and other, which were on the slide, and radiotherapy has also been used. Then a complete metabolic remission was confirmed in all 4 patients at the end of the healing process, and patient's disease status was evaluated dynamically by PET and CT method every 6 months, and relapses occurred at different times, from 10 to 26 months after treatment. Then 2 patients received 4 cycles of BV plus bendamustine, and a complete metabolic response was observed. Both patients underwent autologous stem cell transplantations, and patients are under follow-up, and 12 months have seen no recurrence. Then 1 patient had a complete metabolic response after 4 cycles of BV plus bendamustine. However, it was not possible to collect enough CD34 plus cells for stem cell transplantation. Therefore, the patient was advised to continue the monotherapy of BV. So we again use target therapy in this case. And of course, we understand that there are different cases and different reactions. Then, blood stem cell collection, CD34 plus. This is a heme cell mobilizing regimen. You can see on the slide. So, harvested cell dose is 1.1 on 10 million cells, and it's according to the EBMT. So we follow these standards. Then 1 patient received only 2 cycles of BV plus bendamustine, and the patient's parents refused to continue treatment, and the patient died 9 months after the last cycle of chemotherapy, unfortunately. And now I would like to make some summary. BV plus bendamustine treatment with chemotherapy is significantly more expensive per cycle than conventional treatment, but it has high efficiency and low toxicity. Our preliminary results show that treatment of relapsed classic Hodgkin's lymphoma in children with targeted therapy is feasible and effective. Thank you very much for your attention. Thank you very much. If you have any questions, please, you can ask. Thank you very much for your report. I have also some questions. We see that the transplantation will be the future in our country, and about the transplantation, we can see that it can be done with patients with different kind of diseases, not only with oncological and oncohematological diseases. So, and also the minimal remained. Do you have any like how you define this minimal remained disease? Like, thank you very much for your question. And of course, yes, we also see that it is the future for our country, and we are going to really integrate it in not only into our practice, but we see that it will be expanding to the whole country. And about the minimal remained disease, we have some standards and we have some protocols. It is also depending on what disease and what what was applied, like transplantation and actually what was this. And we of course use MRI, and it depends on the transplantation type. And also, of course, we track the remission. We have also some periods of time, and then we do the tomography, and we also see how transplantation is. Like there are some standards after transplantation, and we check according to this like guidelines and standards. And of course, we use MRI. We use other. We have other metrics of measurement and doing these examinations. And also depending on, for example, in case of leukemia, we also look at, we use MRI and we see the lymphomas and we see how it is going with. And positron tomography is also being used. So my question is around keeping this, like, do we have like cryo laboratory or something in our laboratory? In our hospital, we don't have a place for keeping, and that's why we use. We don't keep it in our clinic, and we have some other techniques how we can have it, and then we do the like there are some regimes that up to 5 days you can actually keep it in the fridge, and we follow, of course, all the standards, but we don't have the cryo laboratory in our hospital, and we don't keep these materials in our hospital. But I really see that in near future we will think of this freezing system. We will see the opportunity of really having this in our laboratory. I think it should be there.
Benim söyleyeceğim Nigar çevirebilir. Ben Nigar'ın sorusunu anladım. Şimdi Rüstemova benim söyleyeceğimi çevirebilir. İyi olur. Anladığım kadarıyla yine kriyoprezervasyon olmadan nasıl otolog transplantasyon yaptığınız gibi bir soru soruldu. Meslektaşımın söylediği doğru. 4 derecede buzdolabında 5 gün tutabilirler. Yüksek oranda kök hücre toplarlarsa o viyabilitesini kaybetse bile yüksek oranda olursa %50 viyabiliteye inse bile canlılar otolog transplantasyonun başarısını yaratırlar. Bu bir yöntem gerçekten.
Hocam aytyaptilarki, doktorning savollarida, ya'ni berayotgan javoblari to'g'ri.
So the moderator also confirms that the response is correct, that it can be kept, the materials can be kept up to 5 days in the refrigerator. But of course, in order to organize these processes to work flowly and without any problems, there should be a special laboratory, and with this, and there are specific equipment, and it also depends on the conditions of keeping. And of course, everything should be organized according to the standards. And we also didn't start with the laboratories from the start, but now everything is organized. Thank you very much for your responses, and we are going to continue, and we have another presentation. And we are going to have the topic infection control in the pediatric oncology department, and Professor Migaela Kaniza from Austria.
This lecture in this educational event. I will focus on key interventions to decrease risk and transmission of infections, especially in children with cancer. Agent, host, and environmental factors interrelate in a variety of complex ways to produce a disease. For control and prevention measures of an infection, usually it requires assessment of all three components and their interactions. The infectious agent can be a virus, bacteria, parasite, or other microbe, must be present for a disease to occur. A variety of factors influence whether exposure to an organism will result in a disease, including the organism pathogenicity and a dose. Host is the human who can get the disease. Factors intrinsic to the host or risk factors can influence an individual exposure, susceptibility, or response to a causative agent. Environment refers to extrinsic factors that affect the agent and the opportunity for exposure. Environmental factors allow transmission of the agent. So the best way to prevent an infection is stopping the transmission of an infectious agent to the susceptible host. With this epidemiologic triangle in mind, to decrease the risk of infection in a susceptible host, let us review 6 important concepts. These are lowering the burden of pathogens, improving nutrition, improving immunity, practicing clean care, practicing clean processes, and preventing antimicrobial resistance. According to a publication, a human has about 30 trillion cells and 39 trillion bacteria. Lowering the burden in some areas of the body can decrease the potential for infections during critical time. We will review how to decrease this burden. The skin is a constant source of pathogens. Chlorhexidine gluconate bath uses 2% chlorhexidine wipes, which are disposable, moistened with a rinse-free 2% chlorhexidine antiseptic solution cloth. Chlorhexidine kills 99% of the pathogens on the skin. The wipes should be used as instructed on the child's skin. The standard use of these wipes are based on the body weight, and each wipe should be used only in the recommended area as shown in this illustration. If a child is under 20 pounds, use 2 wipes, one above the belly button and another for below. Do not use on the head and face. If the child is 20 to 60 or 65 pounds, use 4 wipes, and those above 65 pounds use 6 wipes. Using chlorhexidine 2% on patient produces a residual effect that reduces skin colonization with AMR agents such as MRSA, DRE, CRE. This beneficial effect was demonstrated by investigators from Cook County Hospital in Chicago, who studied the effect of decreasing the burden of patient skin colonization with VRE by using chlorhexidine wipes and evaluating the contamination of surfaces, healthcare worker hands, and the patient acquisition of VRE. A risk ratio is displayed here, and compare the 2 methods of patient bathing, one using wipes with 2% chlorhexidine versus non-medicated wipes. This study demonstrates the protective effect of wipes impregnated with chlorhexidine for skin contamination, environmental contamination, healthcare worker contamination, and patient acquisition of VRE. Now, let us review the burden of pathogens in the mouth. There are billions of bacteria in the mouth, with over 700 different species of bacteria. During cancer treatment, careful oral care is recommended. Oral health is very important, especially during cancer care. The recommendations vary if this is before or during the cancer care. At diagnosis of cancer, it is recommended an oral screening which will diagnose dental diseases and lay out plans for caries prevention strategies. If dental treatment is necessary, they should be done considering the ANC, platelet count, hemoglobin, coagulation profiles. Also, any dental intervention should allow time for healing. During this time, remove orthodontal appliances. For caries prevention, a dietary counseling with low carcinogenic food should be recommended. This diet must have minimal fermentable carbs, and the snacks between meals should not contain added sugar. Now, during cancer therapy, an important problem is mucositis. Mucositis should be graded in mild, moderate, or severe, and monitor this problem while using good oral dental hygiene, hydration, pain control, and antimicrobials if necessary. And should include also the control neuropathic pain. Xerostomia produced by the damage of salivary gland increases the risk of caries and infection. For this event, use saliva substitute and encourage water sipping. If lips are chapped and angular cheilitis appear, treat with lanolin-based creams and ointments. Cancer produces an increased needs of energy, but unfortunately the patient with cancer tend to eat less. Malnutrition can decrease immunity, increase risk of infection, and fever and neutropenia events. Therefore, to stimulate immunity and prevent infection, it is important to assess the nutritional risk at cancer diagnosis. The Strong Kids is a nutritional risk screening tool developed according to the newest European Society for Nutrition guidelines. Information provided by this tool correlates with the nutritional status during hospitalization. The tool allows categorization of children into 3 risk groups, combining history of weight loss, clinical impression, and questions regarding nutritional status. Then the child can be classified as low risk, medium risk, or high risk for malnutrition. Once the risk is determined, a specific intervention can be provided and follow up while hospitalized. Recently, investigators assessed nutritional risk at cancer diagnosis using Strong Kids tool. They measure BMI, Z-score, and weight loss, review data about survival and number of hospitalization for febrile neutropenia in the first year after diagnosis. 126 pediatric cancer patients were studied. At diagnosis, 36 patients were at high risk of malnutrition and 6 were malnourished. Risk of mortality and rate of infection were increased by malnutrition and rapid weight loss in the initial phase of treatment. Multivariate analysis showed the effect of weight loss at 3 months on both survival and infections and the independent impact of a high risk of malnutrition diagnosis on infections. Evaluation of nutritional risk at diagnosis, monitoring nutritional status during treatment and interventions improved survival and prevented prolonged hospitalization for infections in childhood cancer patients. Another infection prevention strategy is improving the immunity of children with cancer. According to the literature, some recommendations on vaccination in pediatric cancer patients are as follows. Before chemotherapy, live vaccines can be given at least 4 weeks prior to planned immune suppression, and if possible, inactivated vaccine at least 2 weeks prior to planned immune suppression. During intensive chemotherapy, vaccination could be effective for some vaccines, such as hepatitis A and B, but vaccinations with toxoid, protein subunits, or bacterial antigen should be postponed to less intensive phases to achieve an adequate immune response. The administration of live attenuated virus vaccine is not recommended during this phase. By the time of completion of chemotherapy, insufficient serum antibody levels for vaccine-preventable diseases have been reported, but the immunological memory is preserved. Once immunological recovery is completed, usually about 6 months, response to a booster vaccine is generally good and allows patients to be protected and also to contribute to herd immunity. In addition to these recommendations, more recently the CDC recommends for those 6 months and older who are moderately or severely immune compromised to get at least 2 doses of the 2024-2025 COVID-19 vaccine 6 months apart. In a publication a few years back, we organized this information for immunization based on the status of the primary immunization series. In general, except for live infectious agent, all other immunization can be safely given following a routine schedule. Now let us move on with the practice of clean care during healthcare. Hospital environment can harbor dangerous pathogens. Patient rooms, especially those highly touched areas, can be contaminated with antimicrobial resistant pathogens. Patients can contaminate but also can acquire AMR pathogen from previously contaminated surfaces. In a prospective study done by Moody and collaborators in 2 hospitals in Michigan, they evaluated patients' hands in contaminated environment but also in acquiring new pathogens. The study showed that the patient room and the patient can already be contaminated with AMR pathogens at baseline upon arrival to the room, and that the patient and his or her room can acquire new AMR pathogens during hospitalization, and the hands are an important vehicle for contamination. The teaching point of the study is that in addition to instructing patients to do hand hygiene, room must be cleaned daily and exceedingly well after the patient is discharged and before admitting a new patient. Tips for cleaning include prompt cleaning of soil areas with disinfectant solutions, concentrate in high-touch area, know what you are cleaning, and monitor the cleaning performance. Various types of precautions are at the heart of the clean processes. These are essential to prevent infections and their dissemination during healthcare. Let us review these. These precautions are standard and transmission-based precautions. Using consistently these precautions will decrease the incidence of colonization, transmissions, and infections. Standard precautions apply for all patient care. These must be in place for all patients, including hand hygiene, use of gloves and personal protective equipment when indicated, safe injection practices and safe management of needles and sharp disposal, and respiratory hygiene and etiquette. Transmission-based precautions are those precautions done in addition to the standard precautions. These are based on the mechanism of transmission of the pathogen. There are 3 types of precautions, including contact precaution for AMR pathogen like MRSA, VRE, CRE, diarrhea, wounds, droplet precaution for respiratory diseases. Interestingly, during the SARS-CoV-2 pandemic, studies show that infected people can generate aerosol in addition to droplets, and that might require also protection of aerosol transmission. Now, airborne precaution for tuberculosis, varicella, measles is another type of precaution. In addition, universal contact isolation precaution can be used during outbreaks. And finally, protective isolation precaution can be used to maximize the prevention of infection prevention in a child with neutropenia. A key component of the standard precaution is hand hygiene. Training in hand hygiene can improve practices and decrease rates of healthcare-associated infections. Hand hygiene is indicated before touching patients, before clean or aseptic procedures, after body fluid exposures, after touching patients, after touching surroundings. Alcohol is effective to decrease bacterial counts in the hands of healthcare workers, but bacterial spores, protozoa, and envelope viruses are not affected by alcohol. For all the indications of hand hygiene, alcohol gel can be used, except when the hands are visible dirty and dealing with pathogens that have spores, such as C. difficile or non-envelope viruses and protozoa, then hand washing with soap and water is indicated. Using antiseptics such as chlorhexidine-containing soaps can leave a residual effect in the hands. This mechanism is used for hand hygiene before surgical procedures. Alcohol foam can decrease skin damage also. Long fingernails, artificial nails, and rings can increase microorganisms in the hands, and it's advisable not to use them. Training in hand hygiene indications and proper technique are cost beneficial. Now, let us review infections that depend on the use of medical devices. These medical devices include endotracheal tubes, endovascular catheters, and urethral catheters. Biofilm formation in these devices often is unavoidable, and this can become infected. Endotracheal tubes can have biofilm infected with pathogens. The aspiration of contaminated secretion from the oropharynx and the pool of secretion above the endotracheal tube cuff can gain access to the lower airway and produce ventilator-associated pneumonia or VAP. Bacterial biofilm form on the inner surface of the tube, and this can be contaminated with bacteria. This can be pushed into the distal airway by ventilator cycling, and in the setting of cough suppression and other comorbidity, the infectious secretion can cause pneumonia. The longer the duration of the ventilation, the greater the risk of developing VAP. Caring for patients in a supine position increases the risk of microaspiration. Also, enteral feeding and gastric content can gain access to the airway. Therefore, the shorter the duration of the ventilation, the least risk of ventilator-associated pneumonia. Another important infection that occurs in hospitalized patients is catheter-associated bloodstream infection. There are two definitions often used interchangeably in the case of catheter infections, but these have different purposes. One of them is a clinical definition of catheter-related bloodstream infection, which is characterized by clinical signs of sepsis and positive peripheral blood culture in the absence of an obvious source other than the catheter, plus one of the following: positive semi-quantitative quantitative culture from a catheter segment with the same organism isolated peripherally, or simultaneous quantitative blood culture with a ratio of 3:1 between the catheter and the peripheral blood culture, or time to culture positivity difference no less than 2 hours between the catheter culture and the peripheral culture. The second definition is central line associated bloodstream infection, or CLABSI, which is a surveillance definition. And this must meet specific criteria, including a laboratory confirmed bloodstream infection where an eligible bloodstream infection organism is identified and an eligible central line is present on the laboratory confirmed bloodstream infection day of event or the day before. When using a catheter, prevention of infections is fundamental. A guideline published by a collaborative effort by major opinion leader societies, including the Society for Healthcare Epidemiology of America, the IDSA, the American Hospital Association, the APIC, and the Joint Commission, recommends specific practices before, during catheter insertion, and after this is inserted. For example, before insertion, it's important to minimize the placement, educate people who place the catheter, and practice chlorhexidine bath before insertion. During insertion, adhere to IPC practices, practice hand hygiene, have all the necessary supplies in the form of a kit, use ultrasound, and use maximum barrier protection, and importantly, prepare the skin using chlorhexidine. After placement, have sufficient nurse-patient ratio, clean catheter entry site, remove catheter if not longer needed, change dressing and use chlorhexidine, change administration set if needed, use antiseptic ointment especially for hemodialysis, and practice surveillance. Here in red are indicated those practices that have evidence, high quality evidence, and the study have no major limitation, that there was a little variation between the study, and the estimates has a narrow confidence interval, meaning that the results were statistically significant. Now, let us review catheter-associated urinary tract infections. Biofilm with urinary pathogens are formed universally in urinary catheters, especially with prolonged duration of catheterization. These biofilms in the catheters become colonized with microorganisms that can be resistant to antimicrobials and the host defenses, and they are impossible to eradicate without removing the catheter. The most frequent pathogen associated with COTI in a report were E. coli, Candida, followed by Enterococcus, Pseudomonas, Klebsiella, Enterobacter. Smaller proportion were caused by other gram-negative bacteria and Staphylococcus. For the prevention, use urinary catheter only if necessary. Consider intermittent catheterization to reduce the risk of urinary tract deterioration. Post-insertion, maintain a closed drainage system. Minimize urinary catheter use and duration of use in all patients. Ensure that only properly trained persons are given the responsibility for insertion. Maintain an unobstructed urine flow and remove catheter as soon as possible. Now let us review about Clostridium difficile infection, or C. diff. C. diff is the most common cause of infectious diarrhea in healthcare settings. The risk factors are healthcare exposure, proton pump inhibitor, exposure to antibiotics, immunodeficiency. Interestingly, cancer and transplantation have about 9 times higher risk in getting a C. diff infection. C. diff is transmitted by person to person through fecal oral route or exposure to contaminated surroundings. Prevention includes rational use of antibiotics, good hand hygiene, and detailed terminal room cleaning. An important intervention is prevention of antimicrobial resistance. Let us review briefly this topic. All the interventions we have reviewed here have an effect to prevent emergence and transmissions of antimicrobial resistant pathogens. These include good hygiene and clean care of patients, their families, clean processes, and the environment of care that need to be clean. Staying up to date with vaccinations, which will protect against diseases and their complications and decrease the use of antibiotics, not only in the patients but also for families. Adding to these recommendations is to follow best practices when using antibiotics. If an antibiotic is prescribed, this must be the right antibiotic at the right dose, given by the right route and during the right duration. Healthcare providers, patients, and their families must be trained on the risk of antibiotic misuse and the importance of adhering to best practices when antibiotics are prescribed. In conclusion, the routine actions we mentioned during this presentation can lower the burden of pathogens and decrease infections. Better nutrition and vaccinations will protect from infections. Practicing clean care and clean processes by using best infection prevention and control practices, including standard transmission-based precautions, will prevent and control infections. All the mentioned practices, including the use of antimicrobials responsibly, will decrease the emergence and transmission of pathogens, including antimicrobial resistant pathogens. And now finishing, the absence of infection is a quality marker of healthcare. Our program aims to increase the survival of pediatric catastrophic diseases, especially those with cancer, by stimulating all the action mentioned in this presentation that will support the best care, which is the right care to prevent and control infections during healthcare everywhere. Here is the list of references used in this presentation. Thank you very much for your attention.
Дорогие друзья, у нас небольшое изменение.
Dear friends, we have a change, and now we have a topic.
And now, well, the floor is given to Professor, Pediatrician, Miriam Minkov.
Нас слышите?
Mr. Minkov, can you hear us? Yes, I do. Can you hear me? Yes, now we can hear you. You can start. Do you see my presentation? No, not yet. We could just see it now. Can you open them? Can you share to the full screen your presentation? Okay, I will try my best. Can you please press F5 F5. Try. Can you see it now? No? Can you see it now? Can you see it now? Yes, okay. Not to lose the time, I will try to speak Russian, so it will be a proper translation. I want to give you a certain overview about the organization of the medical service for the children with oncological hematological disease in Austria. I know that you have the process of reforms within the healthcare sector, and probably you need certain things, and also it will be helpful to use foreign experience. You know that for the last 50 years within the pediatric oncology, there is a success which is very important. And in 60s, 1960s, all the oncological disease were lethal at that time, and now we are saying that we are treating the pediatric lymphoblastic leukosis in 94% of cases, and also myeloid leukosis. It was not treated for many years, and now we are treating it in 70%. And practically, if we pay attention to everything without currently, the Western countries, we are treating close to 70 to 80% of all the patients with oncological diseases. Of course, some of them 100%, some of them 40 to 50%, depending on the disease, or on the stage, as well as biological science, as well as and etc. and etc. And you know that it is important to have the proper system in place, the society and certain authorities who will support that. It started from within Austria in 70s. That at that time, the director of the Saint Anna Hospital. This is the one of the like old peripheral hospital in Europe. It was in Russia and in France, and this is the third one, which was created in 90s. And at that time, the director heard that leukosis can be treated. At that time, we developed the new BFL protocols, and it was and I should have to mention that we need to create a national group. Uh, they created the new group, and they start to implement the German protocol. And in addition to that, he asked Professor Gardner at that time, he was the famous, he is the student of Professor Rehm in Charité. He is born in Italy, and Professor Gardner from 1981, he became the director of the St. Anna Hospital. And this picture shows the St. Anna Hospital, which was created in 19th century, and it was reconstructed many times, and it's updated, and it shows that why St. Anna Hospital, which is associated with the Vienna Medical University as well as the Scientific Institute of Medical Oncology, those are considered to be the main leading hospitals in Austria. Whatever I'm telling the next is about the development of the Gardner professor. He is implementing whatever he is doing in Charité Hospital. He is implementing all the modern protocols, and as we talk about the hygiene is important, certain training of the nurses is important, and etc. is important, and we need to create the new conditions, and it should be those were the steps which improve the survival rate of the patients who has oncological disease in Austria. But at a certain point, less than 10 years ago, he he understood that we should not only implement the different other countries' experiences. Every day there are new challenges that to solve within the country, and that's why he decided to have communication with the social people, with the new good community authority, and he started fundraising, and in 1988, they created the one organization which was working such as an NGO, and they had partnership with St. Anne Children's Hospital, and they start to have certain rooms within the St. Anne Hospital where they develop this research, and they start doing the research works there. At the beginning, it was like an institute, and after this, we have the big building after 20 years, which is rebuilt. And our scientific groups, they are working on different pediatric oncology spheres in order to improve diagnostics, treatment, as well as survival rate of the children with oncological diseases. And this is recognized all over the world, and our institute has this recognition. This is the view of our institute in the current time. It is located near the hospital. What should I say? That the science, as well as that hospital should be located near the institute, and they have certain bridge which is reminding that treatment of patients and development of the new technology should be connected tightly. What else do we have? We still have from certain practices from the 80s, that 3 directors, they created an international group to treat the leukosis. And now we have the working group on pediatric hematology. This is considered to be the department association of the pediatrics. And they have a few working groups, and it is for the development of the pediatric oncology. And we have certain ORCIDS network available, which allows us to collaborate with different companies to create projects to study new medicines and etc. That means that we have a national group, even though our state is small. This is how it looks like in Austria. We have 5-6 centers. One is located in Vienna, in collaboration with St. Anne Hospital. But historically, it's like that treatment of the in Vienna, there are 2 centers available. I'm the head of the pediatric oncology there. One is located within the Graz city, one is in Salzburg, another one is in the Fitz city. Even though we have small country, we have big centers, and we are, of course, the landscape is quite a lot of mountains here in the Austria. That's why it takes certain time in order to reach come from one place to another. They are conducting different treatments on every spectrum of oncological diseases. The only one thing that we do not have, we are providing the bone marrow transplantation in Graz clinic, as well as in Vienna, as well as a little bit in Pittsburgh. And there is no separate department for the bone marrow transplantation. There is just a small unit. And what else is important here? That we work multidisciplinary and multi-specialized way, and wherever there is a new diagnosis, the patient is presented on the tumor board. There will be the pediatric oncologists, the pediatric surgeons, neurosurgeons, the orthopedicians, the radio specialists. They're working there, and practically from the beginning, we are showing that every patient is presented there, and after that we think like, what should we do with this patient, what by the protocol, how the tumor looks like, and we are working with certain doctors about solutions, because surgeon during the surgery he can find certain solutions, but his approach, he should be compliant with the protocol, of course. There is nothing like that. For example, surgeon will remove the hand or leg and in child. there are certain strategies that can be done without amputation. Then we are going through like a case-wise fashion that can be presented, can be involved. And here, for example, I know that certain countries they are doing chemotherapy here, so they refer the patient to the other clinic, and after that, the other clinic is doing some other things. We don't do like this. We are trying to sell patients only refer patients only to receive the radiotherapy to the other department. But generally, we want to do everything with the facility of our clinic. This is very, very important. The second thing what I wanted to mention, when I worked many years ago in Moscow, I know that we start using the German protocol of leukosis treatment, and we raised the survival rate. Although the treatment of the tumors, it requires certain time, because and here we need a multidisciplinary approach, and we need to have a good X-ray people, radiotherapy specialists to follow the proper criteria and not to have metastasis and etc. Because without that, we cannot only conduct the chemotherapy. At the beginning, we thought that it is important to have all the approaches to the local treatment, systemic treatment, and etc. And the most important thing is that these tumor boards, they are done not only in adult oncology as well as the children pediatric oncology. We also have physiotherapy, psychologists, and etc. in order to show that we have certain honor of Austria. In Austria, we have very high survival rate of pediatric lymphoblastic necrosis. This is the result of the multidisciplinary approach. The second thing that we are honored with, in Austria, we are conducting many, many negotiations for about 20 years, to involve NGOs and other budgetary organizations to create the rehabilitation center for children with oncological diseases, which is located not far from Salzburg. And there is a pediatric oncologist who is working there with them and all different specialties. And we provide possibility for this child as well as their family to gather together and support this patient with oncological disease. Maybe even the relatives, they can rest there in this area, and the family has better communications after this. What else can we say? I think the rest is like in everywhere else. Before I finish, I want to show the role of the organization itself. And also family supports us a lot, because in the normal pediatric departments there is one psychologist in every department, but here we have two psychologists within our departments. So that means that there is also support given by families and as other organizations. I know that in your facilities and in your country as well, some other fundings, budget fundings are available, sponsors available, and so you can also involve the psychologist. I think when we talk about the schools, the different family association, they pay for our nurses, their staff units, their hours, and we need certain nurses to make the blood tests. So they might also work from home and etc. They support us. And we have adults who have been patients many, many years ago, and they are survived from osteosarcoma from different diseases. And those people, they created their own organization with another parenting organizations. They always support us. They try to raise the awareness, to involve the government, to the oncology sphere. What is important, by the help of Professor Gardner, we have a very international reputation. We have the Center for Treating the Histiocytosis. We developed the protocols. We have the advanced biological investigations conducted, but what else do I want to say? That we are same like St. Jude or like Princess Maxima Hospital in Holland by the help of Professor Gardner. He he also invited us from, and also invited doctors, psychologists to come from Russia, from different countries, and so they can learn our protocols and they can use these protocols within their own organizations later. And this we conducted the training for 200, 300 people, and after Professor Gardner, he went to the pension, and there is another lady who is working on this, and but now she's 90-year-old, and we closed this activity, but we want to retrieve it again, so everyone can come to our clinic, and so they can be trained, and after this they can learn a lot from us to use it in practice. We don't need to we need to learn the advanced technologies, and of course that's why we need to think about creation of this program for the training of the molecular biology and etc. and within the clinical facility as well. And I think everything is possible to be launched, and this program will be launched soon, and you will have a possibility for collaboration. And in general, in conclusion, I should have to say that we have quite a good organized service, and all the Austrian clinics, they work in close collaboration. We have general groups, working groups, and we try to learn the disease and implement whatever is new within the bed of the patient to the treatment. And what is important is that the parent associations, they are supporting us, and we always need to think how we should have to proceed like St. Jude teaches us. And so we need to put new steps in this. Thank you so much. Thank you, Professor Miriam Minkov. I want to thank you for providing time and sharing with us the organization of the pediatric oncology hematology in Austria. Currently, we have a very good network collaboration on training, of the development, on the restructurization of the service in our country. And we hope that we will meet with you this year. Thank you so much. Thank you. In reality, this is a beautiful speech, and we want to thank our moderators. Thank you for your participation. I would remind that Professor Ali Bülent, the director of the transplantology department in Pediatric and in Acıbadem, he works in Acıbadem Hospital from Turkey, and Ekstandarov Kamaldinovic, he is the head of Scientific Research Center Hematology. Thank you so much for your participation. And now this is the small break, and we will continue from 15:00, from 3 p.m. Please don't be late.